Good morning, everyone. I'd like to welcome you to day 2 of our Board of Administration and Executive Team offsite meeting. And just like yesterday, the meeting is being streamed online from our location in Monterey for anyone who wants to follow along. We also have stakeholders and members of the public here in person with us. We're glad you can be here. There will be public comment periods throughout the day for anyone who wants to share their thoughts. For those viewing online, you can make a public comment over the phone by calling 800-259-4105. And members of our stakeholder relations team will be available to help you. Right now, I'm going to turn it, I'm first going to have roll call.
Teresa Taylor,
Here.
David Miller,
Yeah.
Malia Cohen, Frank Ruffino for Fiona Ma, Lisa Middleton, Arena Ortega, Jose Luis Pacheco, Kevin Palkey, Ramon Rubacava, Yvonne Walker, Melissa Willett, Dr. Gail Willis.
Thank you, everybody. Everyone is here. David's not here still? Okay.
Yeah, he's
Oh,
just
there he
getting,
is.
he's getting coffee.
Okay. So right now, I will hand it over to Ms. Frost, our CEO, for her opening comments, and then we're going to move into closed session.
Yes, and good morning, President Taylor and board members and participants here behind us. Much like the theme from day one, today's sessions represent the next phase of progress being made in our health program, along with what the future of private equity would hold for investors like CalPERS. And then importantly, what we can learn about our operations from the 2023 CEM benchmarking report. We'll then head straight to some business with an action item to approve the 2025 health premium rates for our HMO and PPO plans. As you know, we're facing another tough year of increases brought on by inflation, prescription drug increases, impacts from the Inflation Reduction Act, and if approved, a transition to a single PPO risk pool. As he presents the premiums, Rob Jerzonbeck will also go through the approved service area expansions and benefit design changes. That will be followed by a presentation on healthcare contribution formulas for retired annuitants and premium proposals for the association plans. Don Molds and Dr. Julia Logan will then set the stage for advancing healthcare quality and equity measures. Our first presentation from Dr. Logan is a two-part look at what we're doing to move clinical quality measures forward to hold the health plans accountable for hitting NCQA targets and reducing health disparities. All this is in alignment with our health partners at Covered California, the Department of Managed Healthcare, and Medi-Cal to strengthen our impact on the healthcare market in California. Part 2 is a progress update on behavioral health practices in alignment with those same statewide partners. After lunch, we'll dive into the issues impacting the human capital side of the healthcare workforce in this post-COVID period when staffing shortages and burnout are really impacting our members' access to quality healthcare. We'll also learn about the scope of challenges and opportunities they face and what purchasers like CalPERS can do to support an adequate healthcare workforce poised to meet the diverse needs of our members in all regions where they reside. We'll then change direction and do a little bit more on investing. I know usually day 1 is all about investing and day 2 tends to be more about our healthcare programs, but we do have Jim Coulter, the head of TPG. He will be offering his insights on the evolution of private equity and the critical role it will play in helping to fund the climate transition in particular. We know that we will expect some additional headwinds about our private market commitments as we execute on the increased allocations you approved in March and at the end of our ALM mid-cycle review, but especially as they relate to the often politicized subject of climate investments. Mr. Coulter's insights are especially well-timed to substantiate our strategies and also provide us with information we can share with members and stakeholders to help them understand our decisions. Then we'll close out the day with a session on pension benchmarking, as I indicated, and the work that we're doing to advance our practices in concert with CEM best practices, as well as benchmarking ourselves to a really important peer group around the globe. And Kim Malm, our Deputy Executive of our Customer Services area, and Chris Dahl is the representative from CEM. They'll be doing that presentation for us today. So that does conclude my remarks, and I'll turn it back to you, President Taylor.
Thank you, Ms. Frost. We will now go ahead into closed session to get an update on the transition of providers for our PPO health plans. As this is a closed session, I'll ask all non-essential personnel to clear the room. We'll reconvene in open session immediately following our closed session briefing, which should last about an hour. So everybody, if you could clear the room. back to open session. And we are now, hold on a second, I'm in day one. We are now in the approval of our HMO and PPO plan premiums. And with that, I think I hand it over to you, don't I?
You do, and I will turn it over to Rob, who's going to be leading
Okay.
us through the presentation.
Okay. Good morning, Madam President and members of the board. Rob Darzambek, CalPERS team member. This is an action item to approve the 2025 HMO and PPO plan premiums. Today, we will share two recommendations. The first is to approve premiums with the full transition to one risk pool in 2025 for the basic plans. The second is to approve the removal of UHC's Medicare Advantage Edge plan from our program. All premiums are now posted online as attachments to this agenda item, including the state and regional pricing. Let's start with our recommendation for making the full transition to a single risk pool next year for the basic plans. This is because we continue to worry about the stability of the PPOs. As we discussed in June, I'd like to remind everyone of the 5 key reasons for this recommendation. First, this year's HMO premium increases are improved compared to what they were last year. Second, the basic PPOs continue to experience high medical and pharmacy costs. Despite having the surcharge that was expected to accrue approximately $110 million this year, our current projections show that the funded status of the healthcare fund is likely to improve only minimally, if at all. This is largely due to the unanticipated increases in the utilization of high-cost specialty and brand name drugs. Because the HCF is in such a serious situation, last month, the investment committee approved the team's recommendation for changing its investment allocation from bonds to 100% short-term cash equivalent assets. This was done to protect principal losses in that fund. For a fund of this nature, it is highly unusual to have 100% liquidity. At this point, maintaining a stable population in the PPO program is the key factor to replenishing the needed reserves in the HCF. Therefore, the sooner the transition to one risk pool, the quicker we can stabilize the HMO program by minimizing migration from the PPOs to the HMOs. The final factor that I'll mention is that with a full transition to one risk pool next year, the path is quickened to having single-digit premium increases for the PPOs in future years. Again, this is because more members would remain in the PPOs. Before we take a look at the premiums, I want to note up front that there have not been any changes to them since we met in June. This is actually a positive. Let me explain. As we've shared previously, a few years ago, we greatly improved how we set health premiums to enhance transparency with each plan's proposed rate and improve our negotiating position. Each year, we create a baseline projection for each basic plan and then compare it with the plan's proposed rate. We require the plans to submit their proposal in specific categories using a standard methodology. We also require them to submit an actuarial attestation. Further, we engage an independent actuarial consulting firm to conduct a third-party verification and review. Before we started this approach, we would see changes, and sometimes even large ones, between the June and July board meetings. This methodological approach allows CalPERS to get a much more accurate rate earlier in the process, which is what happened this year and what we presented to you last month. This approach also eliminates the need to go through multiple iterations with the plans. Lastly, it reduces the plan's abilities to lower their rate after seeing their competitors' premiums, which further forces them to compete on cost and quality instead of relying on gamesmanship. So our enhanced process is working, which also improves our negotiating position as we have more leverage before we bring premiums to you and the public in June. And this year, we are not seeing premium changes between the June and July meetings because of this. One last item I'd like to remind everyone of is the timeline to approve premiums. Before the pandemic, we would obtain board approval of the following year's premiums in June. However, in 2020, we pushed that timeline out 1 month, and the board approved the 2021 premiums in July of 2020. Pushing the approval out 1 month gave us an additional month of data to use in our projections, and still allowed a sufficient time to prepare our systems, communications, and member and employer outreach activities in time for open enrollment. Additionally, this ensured that all back-end processes could still be completed after open enrollment, such as sending new ID cards to members before January 1st, as well as taking the correct member and employer deductions from December paychecks and retirement warrants that month too. I share all of this so everyone understands the significant amount of activities that need to take place so our members and employers not only have complete and accurate information about what's changing next year to make an informed decision during open enrollment, but that our teams and the health plans can fulfill critical annual processes after open enrollment so members and employers have a smooth transition on January 1st, regardless if they are changing plans or continuing on with the same one. Any delay in approving rates would seriously jeopardize our ability to complete these critical tasks. Here are the premiums for the basic HMO plans. As before, the numbers we're sharing here are single-party premiums, and the plan-specific slides are in the appendix section of this presentation. And I see we have an extra column there on the row on the top, so we'll make sure we swap that out so that it's more presentable online. The two far columns on the right, in green, show the HMO premiums under the recommended full transition to one risk pool in 2025. The weighted average for these premiums under the full transition is 8.72%. With the full transition next year, the PPO premiums increase is 9.82%, slightly above the HMO weighted average. As mentioned before, this will help reduce outward migration of members from the PPO, stabilize the healthcare fund, enhance our ability to replenish the reserves, and put us on a quickened path to have single-digit PPO premium increases in the future. Now for the Medicare Advantage plans. Again, nothing has changed with these premiums since June. However, with the removal of UHC's Edge plan, we do see a slight decrease in the weighted average of about 1.25% for an overall increase of 12.5%. Additionally, I'll note that we continued to evaluate the premiums for the MA plans in light of the impacts of the Inflation Reduction Act. Again, those are changing the way CMS provides subsidies to health plans for pharmacy benefits. We have confirmed that all of these increases are reasonable. However, for the fully insured plans that are not benefiting from CMS's changes, we are taking an additional step to prevent further unnecessary increases. We are doing this by establishing a premium stabilization fund for UHC and Blue Shield. This means that once CMS establishes their subsidy amounts, any additional increase that was added to the 2025 premiums will remain with CalPERS. Therefore, we will retain any difference between the announced drug subsidy amount minus the amount included in their 2025 premiums. As we shared before, this is a big win for CalPERS, as it ensures that any potential unnecessary premium increases will remain with us and not simply be turned into profit by the health plans. We'd like to again acknowledge the leadership at both UHC and Blue Shield for working together with us on this important safeguard for our members. Likewise, premiums for the Medicare supplement plans have not changed either since last month. Finally, on this slide, we can see the weighted average premium changes for both basic and Medicare plans from 24 to 25. The total weighted average percent change for the basic plans is just over 9%, and for Medicare, it is 22.25%. The overall change for the program is 10.79%. Now let's talk about our second recommendation regarding UHC's Edge plan. You'll recall that this plan has a proposed premium increase of 50%. This plan also started with CalPERS in 2022, offering $0 copays for most services, and now has just over 5,000 members. As you remember, there are a few reasons for our recommendation. First, with United's proposed rate increase, Edge will go from being the 5th lowest cost Medicare plan to the most expensive Medicare Advantage plan we offer, setting a dangerous precedent. Next, and even more importantly, we pursued this with UHC, and they themselves didn't see a viable path back to lower premiums. Finally, with such an unsustainable rate increase, we don't see this plan adding value to our program. Current Edge members can continue with the same Medicare providers they're seeing today by switching to another Medicare plan. For members who don't make any plan change later this year during open enrollment, they will be administratively transferred to UHC's Group MA plan. To summarize our recommendations, we recommend that the board approve the proposed 2025 HMO and PPO plan premiums with a full transition to a single risk pool for the basic plans. We also recommend approval to remove the UHC Edge plan from our program. For next steps, once the board takes action, we will begin our communication activities in advance of open enrollment. This concludes the presentation, and we're happy to take any questions.
Thank you, Rob. I have some stuff to say, but you go ahead, Ramon. You sure? So, actually, these are more questions, Rob. So, I'm going to start at the top, with our basic plans. I just want to make sure as we move forward. So last year we had some not great increases that reflect poorly for us, for our members. And we were hoping to contain those costs this year. It's a little better this year, but not a whole lot. So what I'm hoping to get from you is an assurance that with this transfer over to the one risk pool, which also increased these rates, that we will see, I know we can't ask for no rate increases, but definitely different and lower than what we're seeing here for next year, because these kind of rate increases are the reasons that our members can't afford things. And honestly, I know this was Rob's famous line, but figure out a way to sharpen our pencils and get these down. This is not acceptable. And I know why we have to do these this year, but it can't be like this another year in a row.
So is it okay if I answer?
Absolutely.
One, we hear you. And two, I would say we agree with you. One of the things that is really critical, not just for the economic security and prosperity of our members, but also for the health of our members, is that we keep premiums as low as possible. So I've talked a lot over the years about what happens on the health side when cost sharing gets too high. And premium is certainly one way in which cost sharing gets too high. People forego care and their health suffers. So we are absolutely in agreement, and we hear you about needing to get these lower. A lot of the changes that are reflected in the premium this year are structural changes that we need to make to stabilize this product. And I know you are very aware of that, so I won't belabor that point. Some of those structural challenges, just to be transparent, are going to remain until we have built the reserves up on the PPO side. So we are going to continue to see economic pressure in the form of inflated premiums as long as we have a surcharge on the PPO. We are hopeful that we will start seeing reductions for other structural reasons. One are the big changes that have taken place on the PPO side this year.
Right.
The total cost of care guarantees that are part of our deal with Included Health and Blue Shield. Some of the services that Included are bringing to the table, the care coordination, helping members find the right care at the right time, we think is first and foremost going to improve outcomes for our members and keep them alive and healthy for longer, but also give us some relief on the premium side, because good, well-coordinated care is more efficient than poorly coordinated care. we are embarking, as you know, this year on a procurement on the drug side. Our drug costs have been a major driver of this trend, and we are embarking on a solicitation. We are looking broadly and we are looking creatively at better solutions to bring down our drug costs, which really were the story this year. I mean, we can talk about medical trend and the structural issues are really issues, but our drug prices are coming in much higher than projected, or they should be.
And that's for HMOs that actually have their own PBMs.
It's across the board.
Yeah.
It is across the board, but we are particularly seeing it on the self-insured side. So that is another major change that is coming. So we will have in place by the end of sorry, help me out here on times.
So starting in 2025, we'll have the new PPO contracts in place, and so that has a total cost of care guarantee as well as the quality guarantees. And then for 2026,
Thank
we
you.
will
Yeah.
have the new contract
Yeah.
contracts for pharmacy benefits.
Yeah. So when we circle back next year and we are setting premiums for 2026, they will be reflective of the changes that we will have in place to get better value on the drug side as well. So there are two major structural changes that are imminent, and we are leaning into those to bring down costs.
I appreciate that. And then I want to go, I appreciate that the PPOs, our PERS Gold and PERS Platinum, are a little more manageable. It's still a 10% increase. I know where we are with that and why that's where it's at. So hopefully this helps stabilize it in the next year or so. And then I wanted to ask my last question before I move on to everyone else that needs to ask questions. And Ramon, you're next. United Healthcare Group Medicare Advantage PPO is the highest increase on the Medicare side. We are looking at getting rid of the Edge PPO for Medicare. And you said something about Edge not seeing a path forward to lower those increases. Do we see a path forward for this Medicare Advantage PPO for UHC?
That is a great question. I mean, we're seeing those high premiums, not just with the United PPO. We're seeing a version of them with on the self-insured side, and we're also seeing a version of them, although lower, with the Shield product. So Rob walked you through, I think in June, the IRA changes that are having this impact. There are also decisions that will be made shortly after we meet here that could bear one way or the other on our bottom line on the drug side that CMS will be making. And so some of this will be determined by what choices CMS makes in the coming months. We are also, as I don't need to tell anybody, we're in an election year and we're headed into who knows as a next administration, and there will be implications there for how CMS pays health plans for the services they provide, which is the single largest determiner of our Medicare rates. So there is a tremendous amount of volatility there right now. I can't imagine seeing rates like the rates we were saying on the Medicare side this year, but I also have never seen volatility like this. And when you think about some of the ideological differences in the approach that may be taken, I can't offer any guarantees.
And I don't know, I know that a lot of our members have heard this before, but maybe you want to kind of go into that, why that is, just
Rob,
a little
do you
bit.
want to touch on that?
Yeah.
So the why things are changing through the Inflation Reduction Act and what those
Yes.
are. And so the first thing, one of the things that is happening is they're changing the way that the member out of pocket is calculated. And so the member out of pocket was previously just on what the members were paying, but now they're also considering plan paid plan paid dollars toward that'll apply towards that member out of pocket. And so the members won't pay the $2,000 maximum, but the dollars that the plan is paying to that will apply. And so the members will will benefit from that because there's less cost sharing for the consumer. But for plans like us, then we are paying part of that $2,000 that we didn't used to have to pay. So that's one thing. The second thing that is a more impactful for our rates is the reimbursement process that in determining the subsidies that CMS will pay the health plans. And so that is where we've talked about plans that have members on fewer high cost or name brand drugs will fare better because they have more efficient processes for handling those members. And so we see some plans benefiting. One of those plans, of course, is Kaiser. And so they're benefiting from these changes. Other plans who don't have that strong or engaged like pharmacy benefit management oversight, those are the ones that have more members on high cost specialty drugs. Those are the ones who are actually seeing decreases in subsidies. So those are the ones that we are establishing the premium stabilization funds with, so UHC and Blue Shield. And so those are the two things that are happening. And then the last thing that was talked about was just the timing of CMS's subsidy amounts. Those are going to happen either the last week of July or first week in August. So after we need to set our rates. And so that's again why we have those premium stabilization funds, so that any unnecessary premium increases that are in the rates today will be retained with CalPERS. So they will not turn into
So in
profit by the
case
health plan, just in
The
case.
rate setting actually goes lower than okay.
Correct. Then we will capture that here and retain that with CalPERS, and then use it in future years for our members.
Yeah, and that frankly is a very big deal. This is the second year where we've seen these Medicare rates are significantly higher than they were last year. But if you recall, Medicare rates started going up last year after a number of years where we were seeing flat or negative rates.
Yes.
In those years where we were seeing flat and negative rates, the federal government was being extraordinarily generous in their reimbursement of Medicare Advantage plans. 2 years ago, they started tightening the screws. So you all have been reading about these changes to the way that the coding and some other major changes in the way in which CMS reimburses, but they've also changed their formula. Those are important steps that CMS needs to be taken to shore up the Medicare Trust Fund and to ensure that Medicare will have the money to pay for benefits well into the future. So those are things that we believe need to happen. At the same time, after an environment where things were far more generous, plans are not getting as much money, and premiums are the place that they turn to next. So those are the two sources of money, and if one dries up, the other one gets worse.
That's a longer conversation for elsewhere. Thank you very much. So Ramon.
Thank you, Madam President. I know the rates are not where we want them to be, but I want to thank staff for all the work they did to ensure that they're, I'll use the word justified, meaning that they meet requirements under our governance rules. But I also want to acknowledge that in our effort to ensure that we have competitive rates, we were able to see some expansion into Northern California by Blue Shield Trio and United Healthcare Harmony and Kaiser into the various parts of Northern California. But I'm particularly pleased to see that that HealthNet Salud de Mas will be expanding to the Imperial County, and I want to thank them for that. So thank you. Thank you, Madam President.
Thank you, Ramon. Next I have Yvonne Walker.
I want to make sure I'm good because I don't want JJ to yell at me again from the back of the room. Okay, so one, and you might have said this, but I just want to make sure that I don't. You know, when we go into open enrollment, they have the charts that say, so this is how it will impact you personally, right? And so when does that chart come out? Because people are looking for that.
So I'm gonna, because Rob used to be, I would ask Yesenia, but since Rob has a microphone, I will ask Rob to outline the dates.
So the members will know when a member logs into their CalPERS account, the accounts will be uploaded with all the information on what is exactly happening for you the 1 week before open enrollment begins. And so that is where everything is uploaded, where they'll see if you do nothing and stay with this same plan, this is what's happening with your out-of-pocket and cost sharing. That'll happen. That is 1 week before open enrollment begins. So it'll be September 9th is when that's ready. And then then open enrollment begins on September 16th. So that is when that actual very personalized and tailored information will be ready.
Thank you. Thank you. And then included health. We were going to bring them on like right after this meeting. So when do they come on? Because I've kind of hyped this up, and so I want to know how much hype.
Certainly. So yeah, so Included is now, we have an intent to award to both Included and Shield. We are moving forward with implementation for both of them. We're meeting with the teams on a
All the
daily
time.
basis at this point. So we are excited about the services they will be bringing to our members.
Okay, but how soon?
Well,
Or included specifically?
So included will come on early to help with transition. Is it August 1st?
So
when they're formally?
we had a conversation with them yesterday about this, and so we wanted them on board the 1 week before open enrollment begins, so September 9th, the same time when all of that information is ready for our member, that their call center will be up and running by then. In advance of that, we will be sending letters, and we've talked about emails and letters to members sharing what Included Health will do and the role they will serve. However, they won't be ready to help a member until 1 week before open enrollment and through open enrollment, because that's really when we want the members to get assistance in validating that their provider is in network, or talk through the options that we've talked about last month about the other mitigation efforts that Blue Shield is putting into place. And so that's really when it's closer to the decision time versus having them on board right now when there's less concrete decisions to be made.
No, I do understand that, but because we're going through a transition, I know that people have questions because I got asked a lot
Yeah.
at the last meeting I was at, and I don't have an answer. And so that feeds into anxiety people feel
Yeah.
about a change. So if it's possible, it would be helpful to have people be able to ask their questions sooner. And I get that it's not about the decision, but this is about, making people feel that they're understanding. It takes more than just getting it before I have to make a decision.
Yeah, no, you're right. It is something that we are concerned about. As Rob mentioned, we're starting communication. We've started communication. We are doing webinars. Our marketing team, which usually is charged with bringing on new employers, we're redeploying for the purposes of going out and meeting with members and talking through this very large change for us. We have webinars planned. We are including communication in our newsletters on this. We have been working with Kim's team, the call center, so that they are prepared to answer the questions of our members. I will say this to folks who represent members and who are here or who are listening. I've had some of these conversations with you already, but we see all of those organizations as vital lines of communication to get the word out. A number of our members are represented. We've talked with some of the unions who represent them about using their lines of communication to talk about these changes. We are very, very excited about these changes. We think they're going to be positive for our members. We think that it's going to improve their health, and we think it's going to make our PPO in particular more efficient. But it is different, and to your point, it is anxiety provoking. And so if there are other avenues that we could be exploiting to get the word out and to answer questions and to put people at ease about this change, and to talk through how it can work for them, we are all ears.
Yeah. And I agree with you, and I support and believe that this is the best path forward. I'm excited about it. I think it's the right thing. So it would be helpful for me as you get your the webinars that you're going to have and the different. If I could get the list of when they're going to go out, then
Yep.
when people ask, I can
Yep.
just send it out to them. That would be helpful.
Great.
Okay. And then one more question, and two more questions that are not necessarily here about this, but the Supreme Court case in Chevron, right? And as I understand it, it is taken away from administrative agencies, how they interpret the laws or whatever. That's a simplistic thing. However, recognizing that CMS does a lot, right? What scenario planning are we doing now? We don't know how the election is going to end. And I believe if we wait, but the decision is still out there. So if we're not doing scenario planning now, I think it is a mistake. And so are we? And how are we preparing for this?
So I'm gonna, if it's okay to just phone a friend, I will say we've had some conversations about Chevron's implications in healthcare. We've been talking to our DC folks about it. We've been thinking about it a little bit internally, but I'm gonna let Matt start and maybe talk about Chevron.
And just to be clear, Matt, too, it's not necessarily about the Chevron decision because that's there, right? And I don't necessarily need a full
yeah.
but I do want to know, CalPERS, what scenario planning we're doing
Yeah,
to prepare for that, good or bad,
yeah.
which is less of a legal opinion and more
Yeah.
of a
The
organization
short
opinion.
answer is we're still trying to fully understand its implications. I can tell you that just as they are in environmental regulations, there is a lot of discretion that is left to CMS in particular. That impact, I think, is felt more strongly in the Medicaid space and on the marketplace space. So the marketplace folks are, covered California is enormously affected. In the commercial space, less so, but certainly there are lots of other implications. So our DC folks are working on a full write-up to talk through to work through how it might affect or would affect CalPERS. We are happy to share that analysis with you when they are done with it. It may be a good thing to queue up for a future education session or board meeting. So, but it is early days for us, and we're starting to look about it, and we're certainly look at it. We're certainly talking about it, but I can tell you that that there is a lot, particularly with respect to the Affordable Care Act, that was left to implement to federal agencies to interpret and subsequently implement, and a lot of decisions were based on fundamentally on Chevron, and which ones are in jeopardy is something that everybody is looking at right now.
All right, so I will, the analysis, I think, if you want to give it to us, great.
Yeah.
I'm still more interested in, how we,
Yeah.
how we get there, right? And
Yeah.
so, and I know that it's early days and everything else, but if we don't start talking about it and start that pathway,
Point very well taken.
we'll be at the
Yes.
end and then be
Yes.
like, ugh.
Yeah.
Okay. And then my last question, and this is not question, but information that I would like. All right. So, and I don't know if the board has ever had this conversation, but I'd like to know. So we have the PPOs, the HMOs, and on one hand, with the PPO, some of the PPOs, it's for our members that don't have any other options. And then some of it is for our members that prefer the flexibility of the PPO plan. And so what would be the difference if we said, if you live in an HMO area, you don't have an option for the PPO? What impact would that have on the PPO fund? How would that, play out? And And then how would it impact for folks that have no option, right? Would be helpful, I think, as we make decisions about how we're moving forward and everything else. Because it's not unusual for employers to say, like, this is your plan, period. And so I just want to
We-
know, because I
we-
think it will be
we
helpful for the
can-
conversation.
We can do that analysis.
Okay.
Yeah.
And I think
Is that,
that's all I got.
Okay,
Thank you.
so the direction of the chair, okay?
so I'm taking that as direction?
Yeah. Just understand, I think I've talked to a couple of our members. Huh? Oh, because I'm turning my head. I've talked to a couple of our members who actually chose the PPO because for whatever reason, their children have special needs and they have to have these doctors out of network, that kind of thing. So does that get included in this analysis? How many?
That wasn't, that's
That's
something
hard.
certainly we could look at.
Yeah.
But, well, I actually don't know that we could look at that
Yeah.
in a meaningful way because you would have to speculate based on, that would get
Very, yeah.
extraordinarily difficult to tease out. I will say this, I'll remind folks that we do not have an HMO or EPO option in every single zip code in California, but we do now have an HMO or an EPO in every single county in California. And we are closing in on every single zip code and hope to get there. So one of the things that we did over the last 3 years or so is we filled out our HMO network. Now, it is a broad base. It's a Blue Shield product. It is a broad base. It's tagged in sort of premium cost to the Blue Shield Access Plus product, which is still a broad network HMO. So it is not. It is more expensive than the Gold product in some of the counties. So we were up in Shasta about a year and a half ago. They pegged their reimbursement rates to the Gold product, and that is not uncommon. So for middle income and lower middle income folks, that Shield product can be a stretch on the premium side. On the other side, very low cost sharing, much higher cost sharing on the Gold side. We are trying actively, as you know, to bring low-cost HMO products into as many of those rural and quasi-rural counties as possible. We are tremendously excited about having low-cost options in Shasta now on the HMO side, and we are pushing our plans to expand into some similar areas. But sometimes people pick the PPO because it is quote unquote the only game in town. Increasingly, it is because it is still the lower cost product, and it is what they can afford, and because the HMOs that are in there are still among our higher cost products. So that's the challenge. We can think about how we tease that out in this kind of analysis, but this is certainly a kind of analysis we can
So
do.
Teresa, can I do follow up? One
Sure,
more?
go ahead.
Yeah, and I appreciate that. And this is more about making sure that we have the knowledge we need as we start talking about these things. And some of this gets driven for me by saying, like, we don't want the HMO to subsidize the PPO, and what does this really mean? And so I want to make sure that I am having the most informed conversation, and not just talking.
Sure.
And then another thing, it occurred to me while you were talking, and I don't know if this goes into the same thing or it's a separate thing, but when we were in COVID, right, the Western states had a coalition as they were looking at getting different things that dealt with COVID and everything else. And so would that be helpful to look at? And I don't know if it can even be done. This is something I've pursued for a long time, so I'm going to continue pursuing it because it makes sense to me, just so you know. But, I mean, like, we've got, Washington, Oregon.
Yep.
Why are we not having more of a regional approach
We are thinking
to
about
getting
that.
covered?
I will share that we are thinking about that.
Absolutely, because we have folks like up in
Yeah.
Del Norte that, they're living in Oregon.
Yep.
And it doesn't make sense
Yep.
that we're
Yep.
not having a more collaborative approach to
Yep.
this.
No, yes.
So I
It's a-
look forward to
it's a
hearing
great-
more
it's a
about
great-
that.
It's a great thought. Yeah,
I look forward to hearing more about that.
yeah.
Great. All done? Okay, I know, right? Jose Luis?
Thank you. Thank you very much. And first of all, I want to thank staff and Rob and everyone for this. This has been, I imagine, just a amount of work and so forth. So I want to be very thankful. I do want to make a comment. As President Taylor mentioned, these rates are just, they're just too high. It's unfortunate that, after we got out of COVID and we've been brought that because of the COVID and high utilization that these rates are just creating this friction. But I wanted to bring up another point as well, because as I recall, one of the other drivers other than the pharmaceutical costs are the medical inflation. And, I've noticed that in the news and recently that inflation has been coming down. And I'm wondering if because of that, and it's I think it may actually come down to where we want it to be, which is I think is 2% in the world. I'm wondering if that will help next year in terms of that. And if you guys could elaborate on, no crystal ball, but you can provide some sort of perspective.
So that's a great question. I've said this in the past, but there is certainly a relation between general inflation and medical inflation. So labor is a significant portion of medical costs, materials, electricity, all of those things that are impacted by inflation, also not insignificant parts of overall medical costs. They do not work together perfectly for a number of reasons. There are fundamentally dysfunctions in the medical economy that are unique, or the health economy that are unique to the health economy. And in California, in particular, a lot of that is tied to secondary considerations like consolidation. So, we have some areas that perform very, very well. There are parts of Southern California that are still very competitive, where rates that hospitals and providers are charging are much closer to the rates that you see in Medicare. And then there are places where it is 3 or 5-fold Medicare. And a lot of that has to do with competition, or more specifically, the lack of. So some of the things that drive general inflation are going to bear on our costs, certainly, but there are also some other things that are messing with medical costs, and that is on this side, competition. On the drug side, a lot of it has to do with secondary issues also, like when really expensive drugs are coming off patent, or whether a drug manufacturer is successful in keeping it from coming off patent. And generally our inability to negotiate in the drug space on cost, which is terrible for America and affects us in very negative ways. So they are related, but they are different. And typically annually you will see a CPI and then an independent projection about where medical costs are going.
Okay, very good. Then I was just trying to understand that relationship, and I think it provides a good perspective for our members to have that.
Yeah.
So,
And Office of Healthcare Affordability in that board, which is set as you know, because we've talked about this, the spending growth targets, is trying to get at a lot of that. It will be interesting to watch and see how successful the state is in getting there. It's certainly, they have set ambitious targets. They are reflected in our contract, I am proud to say.
absolutely.
But those kinds of differences, some of the questions about the powers that the Attorney General has to review mergers and acquisitions is going to bear on this. There's a lot at play.
Okay, very good then. Thank you very much.
Thank you. Next, I have Controller Cohen.
Thank you very much, Madam Chair. Again, good morning, everyone. Just a quick question on, for clarification. One of the major cost drivers, according to one of the appendices that you put up, was in addition to medical and pharmacy, you also have risk mitigation, which can kind of be a little bit of a nebulous definition. I was wondering if you could add some clarity as to what exactly is risk mitigation.
Sure. So risk mitigation is how we manage and hope to manage a stable portfolio for all of our 1.5 million members. So it means that we are assessing the risk of the population that is in every health plan. And so for health plans that have a sicker population, they have a higher risk score, and therefore they receive dollars from the plans that have a healthier population, so that the plans are competing on the cost and quality of the services they're providing, and not on the health status of the members. So if you were to do it on the health status of the members only, you would see that health plans would continue to have sicker members, or more sick or less healthy population. It would continue to drive those costs up and up and up. And then the members who were the sickest in that health plan, they would remain, but everyone else would then migrate to a lower cost plan. And so it's really to stabilize the portfolio so you don't have that happening, where you have this constant shift of members going from high cost plans to low cost plans, and then you'll continually have plans that need to exit because they're no longer sustainable. So that's something that we don't want. And we want to make sure that we have sustainable health plans for everyone, instead of being in a position where there's always this cycle of this next one is going to fall off because there's too few members in it to remain a viable product. And so that is why we do it. It is very common in the industry that it be done that way, especially when you have so many offerings and so many different and so many members, where we're trying to cover members across the entire state. It's not just we're one company located in Sacramento, California, where we have a little bit more control on where our people go, like picking one plan for all employees. This is something that is very common in this scenario, where we have so many different health plans and we're trying to cover so many different members and offer them choice. So that is what risk mitigation does, and what it is doing here for the portfolio.
Thank you, Rob. Thank you.
Did you want to add the part where that risk mitigation also includes the PPO plans now?
So it does include the PPO plan. So with what our recommendation is to make that full transition into one risk pool for both the HMO plans as well as the PPO plans. Previously, it was HMOs only were in their own risk mitigation environment pool. Thank you for that. But now we're putting them all together because we know that the PPOs are also seeing that they're at the top of it and becoming less sustainable, as what our concerns were. And so we know our members do migrate between the PPOs and the HMOs, and we want them to be able to do that when they do get sicker or have a dependent that needs to go to a different specialized care, or they want to go out of network. That is what the PPOs are there for. They're also there for the areas where there is no other option. And so that's why we're putting them all together, so we can have this program and portfolio of choice for all of our members, regardless on whether they're healthy today and might not be healthy tomorrow, or they need something that will help better suit their needs. So that's why we're bringing them all together.
That helps you. We have, as you know, we have members in New York, Chicago,
Texas.
and Texas. So
Hawaii.
they're the ones that end up on the PPOs without a choice, and I hear the most from them. So then I have Ms. Walker with one more question, and then I'm going to go to public comment.
So it's kind of bifurcated, two things. So I know you had a schedule of webinars that we were going to do, throughout the year. But now we've had a lot of additional work. Are those webinars still going to continue, and do we have a schedule?
Are these the policy roundtables?
Yes.
Yeah. So we one of our policy roundtables will be today. So that is our presentation on workforce.
Okay.
But we are still doing them on a quarterly basis. I believe, is it quarterly? Yeah, it's quarterly.
Yes.
Yeah. So those will still continue to happen. We're going to continue doing what we're doing, which is to have, I think, participation from 2 board members, no more. We will be putting out a synopsis publicly of the details and the learnings. So we're excited about them. We have a long list of subjects we're dying to get to.
not
As
dying.
a policy geek, it is my favorite thing to do.
Absolutely.
A little bit of a lifeline sometimes, to be honest.
Okay.
But yeah, no, those are still moving forward.
Okay. It would be helpful to have the schedule of the topics. Right?
Yes, yeah. We can put that out. I think we've got. I don't want to. I think rather than start clipping them off, we'll send those around.
I
Yeah.
appreciate that.
We don't have them. We have a lot of topics. We haven't landed
Right.
on like the next 6 and how they're going to go sequentially. But I think we have the next one and thoughts about the one after that. And we have a list of topics that most of which were, part of the conversation that we had with you. A couple
Good.
of others we've tried to sneak in there, to be candid.
Okay. That would be helpful.
Yep.
I appreciate that. And I appreciate all the work that goes into that. Because I know it's not just,
We
even though
we
you're a
learn from
wonk,
them.
it's not that easy,
Yeah, no, we learn from them. We're making good use of them. We had, as you know, because you participated in the one on pharmacy, we had really good experts
Oh, yeah.
there that we learned from, and those are the kinds of things that we need to do to keep ourselves up to speed. So it is beneficial for everybody involved.
All right. And then I believe, I know that as we talk about rates and get to rates, right? By the time it comes to the board, a lot of that is already baked in and there's minuscule changes we're going to make to any of that. And so as it relates to rates, right? The work that we do in advance, and I'm not just talking like a year in advance, I'm talking looking forward
Mhm.
and saying, what are the things that we need to do so that we can impact rates going down in the future, right? Because that's where it exists. And so I want to get this right. How are we approaching this? Are we approaching this? That goes back to scenario planning, right? How are we approaching it? Are we approaching it? And do we have the right amount of staff or the right staff to kind of look at that? Because it's 2 different things. One is looking at today, and one is envisioning the things that we have to do to get to where we want to be tomorrow.
Yes. So great question. I know I'm not supposed to say that, but great question. And much,
I just want
and-
somebody
and-
to say
and-
horrible
and-
question.
And
Where'd
much
that come from?
appreciate. Well, you're not going to get it on that one because I like the question a lot. We have a really strong staff. You hear from them, you see it yourself.
Absolutely.
We are not and could never be in a position to do all of this by ourselves. So
Right.
we engage people outside in the world. We engage consultants. We do things like the roundtable. We do things like listening sessions when we're contemplating where we're going to go with a major procurement. We have listening sessions and we talk to all the smart people in the world. We spent months ahead of the PPO procurement talking to the most sophisticated purchasers in the country. We think of them as peers because we think we're reasonably sophisticated ourselves, but talking about what they've tried, what has worked, what hasn't worked, what they're thinking about. That is all great work. It can be challenging to do that work in the way that we like to do it and to make the trains run at the same time because there are many, many trains in this mix. But it is a sort of a constant challenge to sort of make sure that we're doing that work. I think we do a pretty good job of that. We could always be doing a better job of that. There's always room for improvement. So that's, some of that, we have an internal conversation that we have with you regularly also, which is what are our key cost drivers? Like what is pushing premiums higher? What are our levers to address it? We see our contracts as the places where we have the most leverage to make the most difference to bring these down, which is why we're so focused on the PPO contract and why we're so focused on the PBM solicitation that is going to be upcoming. So that is sort of taking that learning using our talented staff to build it into a solicitation, making sure that in negotiations we are asking for exactly what we need is, I think, the best path to do that, and that is how we do it. You know, the other path is, of course, the negotiations with health plans. A lot of that is we have, for lack of a better word, taken a lot of the drama out of that because we now expect them to come to us with very specific data, and we do a completely independent build-up. Rob talks about this whenever he talks about rates, but we are able to see in our data whether they're asking for more than they should, and we know exactly where it is, and we can push back on it, and we are, I think, pretty successful pushing back on it. The challenge is in the underlying drivers, the costs that we need to do a better job of getting our hands on, not in disagreements about money going out the door in claims.
Right. Yeah, and I understand that. And I don't want anybody to interpret any of the questions I'm asking as thinking that the staff aren't good enough or not outstanding in doing what they do, because I think they are. I really appreciate the work and the openness because, you know, Don, I have a lot of questions and a lot of comments, and I got an opinion on everything. So, and you have always, and whoever I've talked to on your staff has always been very open and not impatient, which I would probably be with me.
Thank you for that. And it's a great team, and they work very hard. So I appreciate the acknowledgement.
Thank you. And I will say on behalf of the board that Don and your staff are amazing. And when I first got on the board, I was always asking the questions and calling you up and how can we contain these costs? How can we help our rural folks? How can we help our out-of-state folks? And you invariably came up with answers. We may not have been able to implement them, but no, you guys are amazing, and I really appreciate it. Our frustration, I think, as a board is more about how we mitigate these costs to the best of our ability, right? Because it hurts our members right in that pocketbook, and I feel it too. Every time, you know, I get a little tiny raise, I get most of it taken away by healthcare rates. So I'm going to move on to public comment, and first up is JJ. Huh? Oh, Frank, you didn't text me. Oh, you did. Oh, there you are.
Sorry, Madam President, but thank you. Just a quick comment. And I want to echo the comments that already been made about staff. You know, this is, you know, very complex subject, and it's not unique to CalPERS. It's not unique to us. You know, we all know that the U.S. healthcare system, you know, is very complex. And we also know that in the U.S. has the most expensive healthcare system of any other country. And in some would even argue, I'm not sure if it's the best. But that said, I wanted to share real quick. The treasurer recently had the pleasure of attending a retiree meeting here there in Sacramento. And the number one question that she got almost, you know, was like, why does my health insurance premiums keep going up every year? You know, we cannot afford it, particularly if you're on a fixed, you know, income. And of course, you know, there's not an easy answer. You know, there's the standard answer, and we have heard it just about from different folks today. You know, well, yeah, it's the rising of pharmacy costs. It's government regulations. It's administrative cost. It's inflation, you know, and all this, of course, play a big part. And then we try to explain how CalPERS, you know, even your literature says, well, CalPERS aggressively works to keep cost and premium down. Be assured that our staff is working their heart out. And we hear that, by the way, every year, you know, that we're doing that, and which I don't doubt at all. But the average person out there, you know, it is hard to reconcile when they say, well, successful negotiations should lead to lower cost. And in effect, this premium might keep on going up. So how is that the insurance company profits and in some cases, people say corporate greed, you know, they keep are going, they're out of control, and yet we cannot keep those rate down. I don't know what the magic answer is, and I think we all are seeking, and we all trying, and we really appreciate the effort of staff. But just be aware whether it's Rob old saying, keep on sharpening that pencil, or a new. Maybe we need to find a new pencil. I'm not sure. Yeah, and I do, Don, wanted to ask that we be included on these seminars because that are very helpful, that Ivan was just referring to, will be very helpful for us to defer when the treasurer gets these kind of questions to say, well, this is coming, that will be helpful. Anyhow, just wanted to add that little bit of commentary. Thank you.
Thank you, Mr. Rufino. Go ahead, Mr. Jelinek.
JJ Jelinek, beneficiary. Yesterday, we had an educational event where everybody talked their book, and for the first time, I learned about investments that had no risk or downside. Today, my comments aren't going to make any difference, and I know that, but incentives work. I've listened to people say they want lower healthcare costs, but by policy, this board prefers fee-for-service over the HMO model. And within the PPO universe, this board prefers the high cost, high benefit, low deductible plan over the lower benefit plan. Within HMOs, this board prefers plans that are less efficient and higher costs. We have a benefit design structure that encourages generics. Now, the doctors control the prescription pad, but our members pay more if the doctor writes a brand prescription. And yet at the same time, we encourage the insurance plans to have their doctors write more brands because that leads to higher costs and therefore greater subsidies. These anomalies are going to continue to happen until you fix the risk adjustment and start looking at the health characteristics of the members that are being insured and not just the amount of money the insurance companies are paying out. Risk adjustment makes sense, but it's got to be based on the health characteristics of the people insured, and this board, by choice, deliberately removed health characteristics as a factor in the risk adjustment. I urge you to reconsider that decision. Thank you.
Thank you, Mr. Jelinek. Our next commenter is on the phone for this item.
Hi, President Taylor. We have Sammy Cassis.
Thank you.
Go ahead, Sammy.
Last year I have the value drug prescription coverage. This year was the plus drug prescription coverage, which have raised the price of one of the generic for a 90-day supply to $100. So in the first place, why have we changed the drug prescription coverage from last year? And second, how could we remedy that?
We're not answering that question.
We're happy to reach out to the member and
Yeah.
talk through his particular circumstances if someone can.
So we don't
take those
normally
details.
answer questions, sir, but we would be happy to reach out to you. Do you have any other comments?
No, thank you so much.
All right, thank you. Mr. Darby?
Al Darby, our CalPERS member. I noted a sizable increase, huge increase in the United Healthcare Advantage Plan, Medicare Advantage Plan this year. And I'm wondering if a recent article in the Wall Street Journal maybe reveals some of that increase. They've indicated that the United Healthcare visiting nurse program, which is very aggressively promoted because I've been, introduced to it. That program turned out to be perhaps a scheme to find a way to cause more doctor visits to appear to have been made. Plus the fact that when these nurses call on you, you get a $50 gift card as well. That certainly would be a rather handsome gift to the patient that the potentially the taxpayers are paying for. So it begs the question: is this a program or a scheme to come up with a new profit center? Thank you.
Thank you, Mr. Darby. So I'm going to go ahead and bring it back. We have another caller. I just got it on my phone too. All right, go ahead. We have one more caller.
Yes, President Taylor. Kimberly, go ahead.
Good morning, and thank you for this opportunity to address concerns regarding the action item before you. Specifically, I'm concerned about the recommendation to remove the United Healthcare Medicare Advantage Edge PPO, and I urge you to vote no on that particular recommendation. I've reviewed the committee meeting minutes and materials of June 11th, providing background on this recommendation, and I understand the driving factor in recommending removal of the plan is due to the premium increasing nearly 50%. Chief Jarzenbeck noted it would be the most expensive Medicare Advantage plan, and I would argue that there will always be a plan that is the most expensive. Also, it would not be as expensive as the PERS Platinum Supplemental Plan. Of course, I'm concerned about rising costs, but what concerns me even more is the lack of options for those on Medicare. As a reminder, there will already be one less plan to choose from with Western Health Advantage's decision to exit the market, and so removing the Edge plan would leave members with two less options to choose from. And this becomes especially important for those who live out of state, which is common among retirees. The service area for Kaiser's out-of-state Advantage plan includes a very limited number of counties in only a handful of states. Even more limiting is the Sharp Direct Advantage plan that serves only those who live in San Diego County. Given this, one has to ask how eliminating the Edge plan, which has the ability to serve all retirees in every state, makes sense when the Sharp Direct plan serves only 480 people due to its restrictive service area. Only 3 Medicare Advantage plans offer service in all states. Those are the Blue Shield PPO, the United Healthcare PPO, and the United Healthcare Edge PPO. Chief Jarzenbeck concluded that the Edge plan doesn't add value to your program, but as you compare the benefits of these 3 plans, only the Edge and Blue Shield plans offer a $0 copay for office visits. This is significant for someone like me who has an autoimmune condition that requires in-office injections at least once a week to maintain necessary blood levels. I imagine there are many retirees living out of state who also have chronic health conditions that require frequent office visits. And so if you vote to eliminate the Edge plan, that would leave us either to pay large annual out-of-pocket costs for copays, or it would leave us with only one plan option of Blue Shield. And so to Chief Jarzenbeck's point, I would say that offering choice does in fact add value. In closing, I really appreciated the remarks that Chief Molds made during the June 11th meeting, expressing interest in engaging stakeholders about large changes and hearing from members if it's not working for us. To that end, I hope you will thoughtfully consider my comment today, perhaps as a perspective that hadn't been considered when forming the recommendation before you, and understand that if you vote to eliminate the Edge plan, the lack of choice will not work for many members. Thank you.
Thank you very much. So I'm going to call on Mr. Palkey.
Thank you. I just want to thank the staff and the medical teams for really taking a deep dive into this. And I too am excited for the future and where technology and where health benefits are sort of moving. And with that, I would like to motion to approve the 2025 Health Maintenance Organization, HMO, and Preferred Provider Organization, PPO premiums with full transition to single risk pool for basic plans and the removal of the United Healthcare Group Medicare Advantage Edge PPO from the CalPERS Health Benefits Program.
So it's been motioned and by Mr. Palkey, seconded by Mr. Pacheco. We don't have to take, do we have to take a roll call vote? Do I know? We should? Okay, so if we could do a roll call vote, please.
David Miller,
Aye.
Malia Cohen,
Aye.
Frank Ruffino for Fiona Ma,
I think he stepped away for a minute.
Lisa Middleton, Arena Ortega, Jose Luis Pacheco,
Aye.
Kevin Palkey,
Aye.
Ramon Rubalcaba, Yvonne Walker, Melissa Willett, Dr. Gail Willis.
Okay, the motion carries. With that, I think we were due to have a break at 10:45. It appears that we're a little past that, so.
This next agenda item is fairly short. If you want to
Sure, if you want to do the state of Newton. Okay, let's do that and then we'll take a break.
Okay. Good morning again, Madam President and members of the board. This is an information item regarding the 2025 state contribution and association plan premiums. We will look at the state employer annuitant formulas and corresponding employer contributions, as well as the association plan premium change for next year. Attachments are posted online to this agenda item as well. So here on this slide, we show the annuitant types and corresponding state contribution formulas. In general, there are two groups of annuitants. First is basic annuitants, and those are members enrolled in the CalPERS Basic Health Plan. And second, we have Medicare annuitants, and those are enrolled in the CalPERS Medicare Plan. These two groups fall under different state contribution formulas based on their date of hire and bargaining unit. The 190 formula includes basic and Medicare annuitants hired prior to 2016 or 2017 and includes CSU members. This contribution amount is determined by CalPERS. The employer contribution for this formula includes 100% of the weighted average basic premium for subscribers and 90% for dependents. Next in the middle, we have the 80-80 basic formula, and this is for active annuitants hired on or after January 1st, 2016 or 17. This formula excludes CSU members and is calculated by CalHR. The employer contribution for this formula is 80% of the weighted average basic premium for the subscribers, as well as 80% for dependents. Lastly, the 80-80 Medicare formula is for state Medicare annuitants hired on or after January 1st, 2016 or 2017, and also excludes CSU members. The contribution amount for the Medicare formula is calculated by CalPERS. The employer contribution here is 80% of the weighted average Medicare premium for subscribers and 80% for dependents. On this slide, we can see the tiers for the employer contributions for all three formulas discussed on the prior slide. Those tiers are single, two-party, and family. Now, moving to the association plans. As a reminder, CalPERS does not administer the association plans. The associations themselves are responsible for ensuring that their premiums and benefit changes are appropriate and that their reserves are adequate. For the 2025 plan year, PORAC has made benefit design changes which are shown on the slide. Here are the association plans' weighted average premium changes for next year. Their basic plans have an average increase of 7.31%, and the Medicare plans have a 9.2% increase. The next steps for this process would be to communicate the association plan premiums and state employer contribution amounts to members and employers during open enrollment. Open enrollment starts on September 16th and ends on October 11th. The effective date for these premiums, as well as the 2025 employer contributions, start on January 1st of next year. This concludes my presentation, and I'm happy to take any questions.
Do we have questions? Now that I got that. All right. Well then, so let me ask a question, folks. We are at 11:10. If we do 15 minutes, that'll take us to 11:25. Is that okay with everybody? We're gonna run late for lunch. All right. Then let's be back at 11:15. I mean, sorry, 11:25. Workforce. Board Education, Dr. Logan is going to be starting this off for us. So go ahead, take it away, Dr. Julia.
Thank you, President Taylor, and good morning, members of the board. We are so pleased today to have two incredible speakers to talk to us about a really important topic that I know is on the top of your minds so often, and you hear from members about access issues to healthcare, both in rural and urban areas. There are obvious strains on our workforce here in California. Capacity is a huge issue, and it impacts our members' ability to access care, especially for really much needed services. So without further ado, I will go ahead and introduce our two speakers today. The first to my left is Catherine Phillips. She's the Associate Director of Improving Access at the California Healthcare Foundation. Catherine works on improving access to coverage and care for Californians with low incomes. She supports strategy across the team, develops strategic priorities and new initiatives to build the future healthcare workforce in California, and fosters alignment of workforce activities across the foundation. In her previous role as a senior program officer, Catherine managed the California Improvement Network and led the foundation's efforts to advance primary care, including modernizing payment for federally qualified health centers and public health care systems, accelerating the adoption of integrated behavioral health care statewide, and improving population health management capabilities among providers that serve Medi-Cal members. She continues to lead programming to improve health equity by fostering greater investment in primary care system-wide. She holds a bachelor's degree in anthropology from the University of Oregon and a master's degree in public health from the University of Michigan. We welcome Catherine. I will also introduce Libby Abbott, who will be our second speaker today. She is the Deputy Director of Health Workforce Development at the Department of Healthcare Access and Information. She joined them in 2023. Prior to joining HCI, Libby was the Director of the Health Workforce Program at the Clinton Health Access Initiative, where she led a portfolio of technical assistance to the governments of 12 countries on health workforce planning programs and policy. In this capacity, she worked closely with the governments of several countries, including Ethiopia, Liberia, Malawi, and Rwanda, to design and launch national health workforce strategies, including supply and demand modeling, to set workforce targets, pre-service scale-up plans, and introducing new health professions training programs. Libby also has a background in research, monitoring, and evaluation. She holds 2 master's degrees in public health and international affairs from Columbia University. Please welcome our speakers.
So Dr. Logan, I'd like to, we're having a little trouble with our PowerPoints, so.
Oh, I'm sorry.
I think the board has it, correct? If anybody has the packets back here, they should have it.
Okay.
So if you don't mind winging it without the PowerPoint, can you do it, or?
Do it. I will give it my best shot.
All right, thank you.
All right. Up there, not here. No.
I do. I can just read along. Okay, so you will be looking behind me. All right, and I will be looking at all of your faces. Good morning, and thank you for having me. Julie asked me to give an overview of California's health workforce challenges and opportunities. I want to begin with some level setting, sort of the scope of the problem, how we got there, why it's getting worse, and what we can do about it. So I'm going to start on the first slide labeled workforce shortages. And in short, California does not have enough providers to meet the needs of its population. Today, 5 of our 9 regions fall below minimum national standards for the supply of primary care providers. This includes pediatricians and geriatricians. And when I say below, not just a little bit far below, the recommendation nationally is 60 to 80 per 100,000, and in many of our regions, we're hovering in the 40s. This has been an issue for many years in our rural areas, and particularly the Inland Empire, but recently the Central Coast and even LA County have fallen below, again, national minimum standards. While California does well in aggregate for specialist physicians, we are seeing troubling trends with obstetricians and gynecologists and general surgery, for example. There are reported or projected shortages in many other disciplines: pharmacy, behavioral health, and nursing, to name a few. Some of these, like physicians, represent insufficient core supply, too few. Others represent issues of maldistribution. We have enough providers, but they're not in the areas where the patients need them. And for some, like registered nursing, we have enough, but they are unwilling to work in the conditions in which they're asked due to safety concerns or for the pay available. Next slide. So what caused the workforce shortage? There are many factors. At the most basic, it's an issue of supply and demand imbalance. We have in California a aging population with increasing needs for care. We've seen an increasing load of mental health needs, as well as substance use disorders, and increasing commensurate needs for treatment. And we have an aging workforce. The workforce is aging faster than our population. The median age of a physician in California today is 53. In the rural north, it's 59. And remember, those are medians. So that means half of physicians in the rural north are older than 59. And while older physicians are highly experienced, they tend to work fewer hours as they approach retirement. So one is not one as we look at FTE balances. Innovations such as telehealth, multi-state compacts, which allow physicians and providers from other states to see virtually patients in California, are helping with some of these challenges, but they're not sufficient to address the care gaps. I mentioned earlier that this is a national trend. It is. I think it's important to note that California's rate, for example, of primary care physicians is declining faster than other states, and the aging dynamic, population to provider, is also more problematic than it is in other states. So how did we get here? Go to the next slide. We, as a state, have had generations of underinvestment in health education and training. Today, California ranks 46th among the 47 states and territories that have medical schools for seats per capita. That's how many medical school seats per 100,000 population. We are 29th out of 50 states in residency, so a little bit better there. In the 1960s, California was the world-class medical and health services training institution in the nation, and many would argue in the world. But unfortunately, we did not add seats, again, commensurate with population growth. So that's how we have the imbalance today. That's what it is for medicine. It's even worse for nursing. Last year, only 25% of qualified nursing applicants for bachelor's of nursing programs could be accommodated in our schools in this state. So that means we turned away 75% of our interested, qualified, and committed students. In addition to the shortage of seats, right, that's the core capacity issue, we have declining interest in health services among our youth. Part of that is attributable to increasing debt loads. Today, the debt load for dentistry is $304,000. For medicine, it's $208,000. And for nursing, it's approaching 50. And this dissuades folks from entering those professions, encouraging them to select alternatives. The uptick in nursing is driven in part by the rapid increase of for-profit private institutions in our state due to the lack of public seats available. So those are all long-standing issues, sort of 20 years in the making. There are, however, a number of recent factors that are worsening the shortage. Right slide. California is a high cost of living state, and surveys that have looked at health providers of all types who leave, they often go to Colorado, Nevada, looking for lower cost of living. Minimum wage laws are driving health workers into other industry. Today, you're just as likely to make an equal salary in retail or in hospitality if you're a medical assistant, for example, or potentially even a licensed vocational nurse. And certainly COVID-19 played a huge role in burnout, in early retirement, and in what's called departures. And that's leaving the field before what would be considered a normal retirement age. In 2020, exits surpassed new licenses for vocational nurses. More nurses left the field than entered it. In 2021, exits increased for both physicians and registered nurses. And in 2022, we saw an all-time high for turnover and vacancy time for nearly all positions at community health centers. Now, your members are probably less likely to go there for care than other settings, but community health centers are known system-wide as a bellwether. So when their medical assistants leave to go to Starbucks, it's a pattern that will follow system-wide. Next slide. So let's talk now about impact. The workforce shortages, of course, limit access to care. That's a pretty obvious finding. About 11 million Californians today live in a primary care health professional shortage area. That's not just physicians, but again, team members working in primary care. A major equity concern in our state is that 2/3 of those 11 million people are Latinx, Black, or Native American. But really, everyone is finding it hard to find care, face extended wait times, or have to have additional transportation to get to care. The bar graph you see on the right side, if we go to the next slide. There we go. On the right-hand side of your screen comes from the California Health Information Survey, one of our longstanding surveys on access. And it's found a near doubling of people with all insurance types who report difficulty finding both primary care and specialty care over the last 10-year period. And this has been a real sea change. We've seen troubles with access in the Medi-Cal market forever, but now we're seeing the commercially insured and even Medicare having a hard time. I've been on a wait list for 1.5 years at Kaiser for a PCP in my home area. Very well accommodated at a different facility, but I do have to drive further than I would like to. So why does this matter? In part because we know workforce shortages contribute to poor population health. I do a lot of speaking nationally, and there's a rumor or a bias that everyone in California has a surfboard and a green smoothie, and we're in Monterey today, so perhaps many of us do. But when you look at the data, California doesn't fare very well. We ranked 44th in the nation on a composite of prevention and treatment measures that comes from the Commonwealth Fund's National Health System Performance Scorecard. We were ranked dead last, 50th, for the number of children in our state who do not have a medical and dental preventive care visit on record in the prior year. We scored 48th for diabetic adults without an annual A1C test, and 46th for some of the mental health access and treatment measures. Now, not all of these outcomes are attributable to workforce, but I think many of them have that as a factor. If we don't have enough people in the right areas, it's very hard to get and receive care. Next slide. So the lack of supply was problem number 1 impacting California. Problem number 2 is a lack of representation. Our workforce today does not reflect the racial, ethnic, or linguistic diversity of our state. 45% of California residents identify as Black or Latino, yet only 14% of our medical school graduates identify as such, and fewer than 9% of our practicing physicians. Nurses and other types of healthcare workers fare a little bit better in terms of representation with population parity, but there are really problems across the board among licensed providers. The problem is most acute in the Latino or Latinx community. They are underrepresented in every licensed health profession and every region of the state. And to reach population parity for physicians, for example, we'd need to produce 37,000 more doctors, just to give you a sense of the magnitude of that gap. Next slide. In California, particularly, language concordance is a particular issue. California residents speak more than 200 languages, and 44% of households in our state speak a language other than English. More than a quarter of Californians are immigrants. They come from dozens of nations, and we have a higher rate of threshold languages than any other state in the nation. While many providers report being bilingual or having multilingual capacity, few actually do so in what's called medical fluency to deliver care in a patient's preferred language. And translation interpretive services certainly support language access, but aren't always available. Next slide. Why do we care so much about diversity and concordance? It's certainly essential for racial equity, but it's also essential for patient care. When the race or ethnicity of a patient matches that of their physician, patients report greater satisfaction with care, greater trust, they have greater adherence to medical recommendations, and in some studies receive more effective care. The ability to speak the same language as your provider or care team is particularly important, as I mentioned earlier, and has been shown to reduce or decrease poor clinical outcomes due to miscommunication. Providers of color are also more likely to accept Medi-Cal. They're more likely to serve in underserved areas, including rural areas. So they're important for system-wide access and performance, in addition to individual patient and family outcomes. So those are the problem statements. I went through that very quickly, and we'll take questions at the end. I want to move now into the solution space. The next slide. In 2017, the California Healthcare Foundation, the organization I'm with, as well as several others, launched the California Future Health Workforce Commission. It was chaired by UC President Janet Napolitano, and it included leaders from labor, from government, from philanthropy, from the delivery system, and from education. And we asked them to think ahead as to what changes we needed to make in the delivery system and in the education sphere to really build up and build out a workforce that would be able to meet California's needs. They issued a set of 32 recommendations and identified 10 priorities that have since become a blueprint for action in our state. I don't have time to go through all of them today, but wanted to just share a few examples of where we've seen really important progress. The first is the establishment of the Department of Healthcare Access and Information, which was referred to as the spine or the backbone for health workforce planning and development. Libby's going to share much more about that entity, its vision, and its action to date, but did want to say that was a call out in the commission report and one we are so grateful to have seen move ahead. Recently, we have also seen significant expansion of primary care provider and psychiatry residencies, expanded scope for nurse practitioners who today are now able to have a panel of patients and function fully as a PCP. We've seen significant investment in what's called pipeline and pathway programs to help guide students and learners to the health services and help support them with mentorship. We've seen development of a psychiatric mental health nurse practitioner program, which extended prescribing privileges to NPs with specialized training and have become absolutely essential caregivers for the mental health and SUD crisis in our state and in others, and also notably reimbursement for community health workers who are essential for outreach and engagement. Next slide. We have also been fortunate to see really historic investments in our health workforce with the Newsom administration. You can see the chart here on the right maps out in millions investments made since 2019 and 2020. The biggest was, of course, in 2021. Those were used for residency expansion, loan repayment for clinicians, retention payments during the pandemic, and a variety of interventions for the behavioral health workforce. These have all helped. They have not been sufficient, but they have and they are helping. Unfortunately, this year with the budget shortfall, about $750 million were cut from the otherwise planned workforce investment budget within the state, and we will be looking ahead to figure out how we can bring some of those investments back. We know that it's not only dollars that matter in terms of workforce. We've been pleased to see openness to revise and expand health education within our community college system, our CSU, the California State University system, and of course the UC. The Freedom to Succeed initiative is working on a variety of interventions to both grow those programs and provide better connections and greater portability, including novel programs such as apprenticeships and employer and labor-led initiatives. There's also been growing support from the delivery system, which I think is a real recognition of just how bad things have got on the ground. We have seen in the last 3 years very significant investments from California health plans and large California systems like Sutter Health in not only things that are pretty traditional like loan repayment, but in salary supplements, in housing supports, in all sorts of upskilling, retraining, and other types of initiatives meant to sustain and, of course, expand the workforce. Next slide. So the next, I've laid out a couple of ideas generally on what seems to help guide learners into health education and what helps sustain them through practice, whether that's nursing, pharmacy, physicians, etc. One is to find ways we can increase opportunities for Californians from all backgrounds to enter health. That's engaging interest. It's also removing barriers, financial and otherwise. There's an important role, as I mentioned, for strengthening the skill set of the existing health workforce so everyone is able to do as much as they can, work functionally in what's called interprofessional teams to meet patients' needs. And lastly, to improve well-being and retention and to prevent those early exits. California has a problem with not enough people entering and too many people exiting healthcare. So to really address this workforce shortage and issue we're in, we need to work from both sides towards the middle. Next slide. The California Healthcare Foundation is a private and independent philanthropic organization. As Julia mentioned, we focus on the needs of Medi-Cal, but when it comes to workforce, it's really a system-wide, population-wide set of initiatives. Our board recognized the growing workforce shortage issues and in 2023 launched a new portfolio focused on developing a stronger and more resilient workforce for the state. I've laid out here our approach, 3 prongs to scale the pipeline, to increase diversity and representation across the professions, 2, to modernize education and training to make it faster, cheaper, more attractive, and more supportive for all Californians, and to make sure all health professionals have the opportunity to learn with one another, so that interprofessionalism and community-based training that we know are important for solving issues both of geographic maldistribution and professional imbalances across the discipline. And lastly, to create growth opportunities for our current workers. We're running short on time, so I'm not going to dwell on these, but I'm happy to take questions later about our strategic focus, what we're seeing have impact, and where we're still challenged during the Q&A period. But I wanted to leave you with a few examples of what you might consider doing as a purchaser. Next slide. Because a purchaser is different than a philanthropic organization. I've put these into two different buckets, some things that provide some immediate benefits, that's in the blue, and some things that are longer term strategies in the gray. Of course, they feed one another. When students and learners see health as an attractive field that's sustainable, more people are going to be interested in joining, right? It's a virtuous cycle when it works well and a vicious one when it doesn't. I put in the blue two categories. One are financial incentives or supports you might consider providing. Loan forgiveness and loan repayment programs are a common way, particularly for licensed providers, physicians, pharmacists, nurse practitioners, and physician assistants. Those are particularly effective when they're directed regionally by discipline or in particular settings or for particular types of populations with strong service commitments. More and more, we are seeing salary supplements provided by purchasers and or by plans to sort of top up what they may receive through fee-for-service or through other revenue from their practice. And third, more and more what's called practice startup improvement or maintenance grants, particularly in the rural north, in the LA area, and others where there are still many independent and private practices that are closing, or where a provider wants to retire but can't because no one will buy their practice and the community is facing an access shortage. Folks are stepping in to provide some support to keep those practices open, keep them thriving, and keep them growing for those local communities. So those are from some examples of financial. There are also some contractual. We talked a little bit about how important well-being is as a way to prevent burnout and early exits. Again, particularly for physicians, but really for all licensed providers. And there are a couple of examples there. One I'd encourage you to think about is reducing administrative burden. When you ask physicians who've left California or left the field, one of the most common things they tell you in terms of burnout is paperwork. So think about what you can do there. Pre-authorization, unnecessary QI requirements, anything to minimize the amount of paperwork and maximize the time with people, with patients, has a net benefit for workforce. Purchasers and plans are also joining forces with one another to do that by thinking about APM alignment, measurement alignment, other types of contractual items that make the business of medicine, of nursing, of pharmacy easier and more efficient. Think also about what you can do to support expanded roles, doulas, community health workers, registered nurses in primary care. There are many examples of ways to build out robust teams. And unfortunately today, many plans and many purchasers present barriers for practices doing that because of payment restrictions, billing restrictions, or others. So always helpful to examine those. So those are, again, short-term, immediate ideas. There are some longer-term ones, again, that we are seeing growing and having impact in California today. One is to look at pipeline and pathway programs to help build up interest in the next generation of students and learners in health. And second is to help support them on that journey through scholarships, through tuition subsidies, all the way up through early practice incentives. There are a variety of different programs. You don't need to start your own. Pooled funds are always helpful. And even if dollars aren't available for full scholarships, there is stronger and stronger evidence on the impact of things like mentorship for keeping folks, again, interested and engaged in the long run. So I'm going to end there. Happy to take, again, questions as we go. Thank you for your interest.
Mr. Pacheco?
Thank you, President Taylor. And first of all, thank you very much for your presentation, Ms. Phillips. My first question, and back to the purchase section, is on the loan forgiveness and payment program. I've been reading that President Biden has been pushing the public service loan forgiveness program, expanding it and so forth. How could that, how could we partner with that or, connect that so that we could incentivize more medical students and medical residents to pursue this kind of work and operationalize it in our health plans?
So the National Health Service Learning Corps, and there's a couple of them, are incredibly important programs. As you said, they're run by the federal government. There's one through the Indian Health Program and one population-wide. They're a very effective way for getting folks who trained outside of California to come to California. They tend to have service, or they always have service requirements. So people are a little bit more stable in those programs. Most of them have a 10-year service requirement. They are focused on the areas where there are the greatest shortages nationwide and within a state. So not all of the geographies that you cover or in which your members are experiencing workforce shortages are going to be covered by that. So that's just a caveat. You can certainly magnify and amplify them, let folks know in your communities they're available, and help encourage people. They're very competitive. They are supposedly going to be expanded. We'll see if that happens the next year, but would encourage you not only to rely on that, A, because it's a competitive, and because B, it doesn't cover our whole state. So there are ways, if you had resources or to work with partners who did, to try and supplement those with additional pools of resources.
I see. And the other comment I have is just a comment is with respect under that category, supporting expanded roles. You mentioned doulas, and last November we modified our benefit changes in our basic plan to include doulas as one of our benefits. Do you see other things that we could be doing in that space to with respect to like team-based care and so forth? I'm just curious if that's something you would explore.
Yeah, so there's a couple of categories of other team members which are essential for sort of optimal patient access and care that commonly face reimbursement challenges and make it difficult for a practice, particularly a small to medium-sized practice. So doulas, one example, great to hear you're covering that. Community health workers, peer navigators, peer specialists, or peer supports, which are particularly important for those experiencing mental health or substance use disorder. There are also other types of educators. The licensed and registered nurses can be incredibly effective assets in a primary care team. That's not an issue of reimbursement eligibility, but often of amount. It's difficult to sustain. And some of those, you have to have really large patient sizes. So there are some innovative models across the state, and I'm happy to connect with you on later, where practices are actually pooling resources and sharing extended care team members across multiple practices, so you actually have a population size sufficient for that. But important to think about that chain, like what's in the contract, what's the benefit, if it's allowed and covered, is it covered at a level that would allow a practice to actually hire someone and care for the whole population?
I see. That's it. Thank you very much, President.
Thank you. Let's keep our questions to just a couple. I think Yvonne Walker.
Thank you for your presentation. Sorry, lost my word. So I want to say from the start that you spend money on the things that are important to you, and we have spent years not spending money on our healthcare infrastructure, and we are continuing to say we're not going to spend money on our healthcare infrastructure, right? But so it's good to see that, we're thinking about this, looking at this. One of the things that I get concerned about is when we pit worker against worker, saying, well, we've raised the minimum wage for workers, so they're going to leave the healthcare industry, and they can make just as much over here as over there, depending on what level they're at, as opposed to having the conversation is what should be the wage for healthcare workers. We moved to a $25 minimum wage that, if I remember correctly in the budget, it was 25. Sorry. They were delaying the implementation of, again, you spend money on what's important to you. And I think that that was a wrong thing. As you guys were doing your studies, did you talk about at all the state of like immigration, right? We have a lot of DACA students out there, right? And so with their futures being uncertain, they are potential doctors, nurses, and everything else. And so have we talked about how, immigration has an impact, or immigrants have an impact? Because with the anti-immigrant rhetoric that we have in our nation, I think we are going to get to a bigger crisis than we fully see. And so was that talked about when you were talking about all the different factors of, how to get more people in, how to keep people in, and then also found it helpful to have, for a lot of students that go in, they might be their first generation going to college, or their first generation going to, med school or anything like that, providing them mentors and coaches, right? Because a lot of times they don't know where to ask the questions, right? They think, if we don't have it, then I just can't get it done, as opposed to realizing there's other avenues and other help. And I think that would be incredibly helpful in increasing our pipeline.
Several questions there. Let me go through just a couple quickly. So on the last one, in terms of mentorship, yes, that's absolutely an essential ingredient. We've supported the California Medicine Scholars Program. That's one of those pipeline and pathway programs I mentioned earlier. It has 5 regional hubs across the state, and that is an essential ingredient where they provide concordant mentorship to the extent possible. So discipline, gender, race, experience, etc., to really support students, because exactly as you say, many first-generation students aren't able to get that type of support from their families. They may never have had an interaction with someone who looked like them in the healthcare system before, and really benefit from that type of support in addition to the financial resources. There are a few statewide virtual programs like that. Mia Mentor is a great one that has strong evidence that actually pairs current healthcare workers with students to provide inspiration, motivation, connection, sort of across their journey. And if folks are interested in volunteering for those, there are always open slots. So mentorship, absolutely. It's also important just for modeling what I mentioned earlier, that healthcare is a good industry to be in. Right? I have 2 little kids, and I am reminded every day when I walk them to elementary school that STEM, the M was not for medicine, the M's for math. So we have had generations of kids who've been taught about science and technology, and caregiving, to your point earlier, doesn't have the same social capital as it did certainly when I was a kid. You mentioned immigration. There are concerns about DACA students. California generally has been a very supportive environment, and in fact, there's been some interstate compacts around residency, et cetera, to help students, immigration students from other states come here to continue their learning journey. The other one that comes up as a question a lot is California's reliance on immigrants for healthcare. We have relied, as many other states have, on importing nurses to fill short-time shortages in the past. That continues today. Recently, there have been 2 bills that have gone through the legislature for the Mexico Physician Pilot Program, which brings practicing physicians from Mexico into California. It began in the Salinas Valley, so very close to here. It is now moving through most of the state in the next couple of years and expanding to psychiatry and dentistry. That's been essential, again, for language access as well as sort of ethnic and cultural concordance. That's a 5-year temporary program where physicians come, they return to Mexico at the end of the 5 years. There are other federal programs, HB1J visas, that are somewhat similar. They often have a 3-year turnaround. There are other states. Tennessee is the one that I'm most familiar with that has a permanent placement program. So if you are a physician and you want to move to the United States, you are eligible to do that without having to redo your residency in the United States, which is a requirement in every other state. So that's one way that other states have tried to be inclusive of immigrants, the value that they bring, and also fix these shortages. It'll be interesting to see what California does in the year ahead.
All right, thank you, Catherine. I'm going to stop those questions there. I think we were meant to go through both PowerPoints before we ask questions. Can I get Kevin, Lisa, and Melissa to write your questions down, and then we'll go through the second PowerPoint, and then we can ask our questions. Thank you.
Okay, thank you so much, and good afternoon. Libby Abbott, Deputy Director for Health Workforce Development at HCI. I'm very pleased to be here today. Thank you for having me. I'm going to speak, as Catherine did, a bit about some of the challenges and opportunities related to workforce development in California. I'll focus a bit more on sort of the forward-looking opportunities piece and what we're doing at HCI. Next slide, please. So I'll just briefly introduce who we are at HCI and what we do, a little bit on some of the health workforce challenges and opportunities, although Catherine has expertly covered that already, and then focus on some exciting work that we are doing to develop statewide strategies for the behavioral health and nursing workforces, which will add important precision and visibility to our understanding of workforce challenges and opportunities in the state. Next slide, please. So who are we at HCI and what do we do? HCI works to expand equitable access to quality, affordable healthcare for all Californians through resilient facilities, actionable information, and the health workforce that each community needs. We do that through 5 program areas. Our first program area is around facilities, where we monitor construction, renovation, and seismic safety of California's hospitals and skilled nursing facilities, and provide loan insurance for nonprofit healthcare facilities to develop or expand their services. We, of course, have a work area around workforce, which I'm going to speak quite a bit about today. We also have a growing body of work around affordability, where we look to improve healthcare affordability through data analysis, setting spending targets, and introducing measures to advance value-based payment models. We also enforce hospital billing protections and provide generic drugs at a low, transparent price through our CalRx initiative. And then finally, we have the Office of Information Services, which advances data and data sharing around healthcare, including collecting, managing, analyzing, and reporting information about California's healthcare landscape. Next slide, please. So in the workforce arena, we're really focused on expanding and developing a health workforce that represents and reflects California's diversity in order to address supply shortages and inequities. And we do that by administering programs and funding and publishing actionable data about California's health workforce and training. We've highlighted the piece around reflecting California's diversity. I'm going to talk a lot today about supply and about shortages and about availability, and just want to emphasize that we are not just looking at gross supply or even distribution. We're concerned with developing and expanding a workforce that looks like the population it serves for all of the reasons that Catherine described. We know that improves outcomes and it improves equitable access to care. I also like to think about it as serving a double bottom line. It also creates economic opportunity for communities of color by providing them employment in the healthcare sector. Next slide, please. I'll touch briefly on some of the principles that guide our work around health workforce development at HCI, just touching on 2 that are most relevant to what I'm going to talk about today. The first is that we are really focused on data-driven decision-making, and that's not just for HCI. We do want to make our own decisions based on the data and evidence that we have, and we want to become a go-to thought leader that can provide data and analysis to other partners in the space so that collectively we are using a shared understanding of the challenges and opportunities in the space to drive our action. That relates to the second to last principle, which is around thinking beyond silos. No single organization or entity is going to solve California's health workforce challenges alone. And so it's really important that HCI come together with partners around a shared vision and a shared understanding of the way forward. Next slide, please. Catherine has already shared quite a bit about the challenges in the space, so I'm not going to spend too much time on that. I also want to flag that HCI maintains the Health Workforce Research and Data Center. So if you look us up, you're going to find great data and dashboards speaking to particularly some of the issues around concordance that Catherine has already spoken about. So those questions around to what extent does our workforce reflect the racial and ethnic diversity of the population that it serves, and do we have a linguistic match between our providers and the patients that they serve? What we're looking at here is a picture around the availability of licensed providers versus state population. So we have by county a question around, does the county share of state population reflect the share of licensed providers that they have? Let's take Madera as an example. I'm making up this number. Let's say Madera has 3% of the state's population. Do they have more or less than 3% of the state's licensed providers in behavioral health and medicine? So a couple of things that we're seeing in this image. One, we know that shortages are not evenly distributed across the state, and we tend to see patterns on where there are shortages. So in the rural north, in the Central Valley, and in the Inland Empire. We also tend to see greater densities of providers in the Bay Area, which you can see highlighted in blue here. Next slide. So I've just zoomed in here to give an example of the rural north, which I know is an area of interest and a topic of discussion here at the board. So you can see that when we're looking at behavioral health share of licensed providers versus population, Shasta and Modoc County have relatively equal shares, whereas Siskiyou and Plumas have moderate shortages, and Trinity, Tehama, and Lassen have more severe shortages. This analysis provides some helpful insight, but it is an imperfect picture of workforce gaps. Looking at the data this way assumes that demand for services is evenly distributed across the population, and we know that is not true. Geographically and by subpopulation, some communities have a higher demand for substance use disorder services, for example. Other communities may have an older population and therefore a higher demand for skilled nursing. So to truly understand where we need more nurses and more behavioral health providers, we need to understand where their services are required, which is done through supply and demand modeling. Not something that we have done systematically or at scale in the state in the past. And that brings me to the focus of the remainder of my presentation, where I'm going to share about our strategic planning work that we're doing at HCI, where we are endeavoring to undertake workforce supply and demand modeling to develop evidence-based strategies for health workforce development in the state. Next slide, please. Just to take a step back briefly, HCI has been doing health workforce development for 50 years. Our workforce portfolio has grown very significantly in the last few years, and we now run over 50 programs touching a wide range of provider types and intervention mechanisms, including scholarships, loaner payments, organizational grants, and pipeline development grants. Whereas a few years ago, as Catherine showed, we ran an annual budget of about $40 million for health workforce development, we have had and expect to have about $500 million to drive workforce development over the coming years per year. In this context, strategic planning is even more important as we seek to be responsible stewards of state funds and ensure that we are really moving the needle in concert with our partners. We think about our portfolio of health workforce development in 4 main buckets or bodies of work at HCI. Those 4 buckets are behavioral health, nursing, primary care, and oral health. These are not mutually exclusive buckets. We know that nurses support primary care and they support behavioral health. However, it's instructive for us to take each body of work and each body of funding and be very targeted in thinking about what we want to accomplish with that body of work and with that funding, and what are the best set of interventions to achieve our targets in each area. Catherine already mentioned, for example, that for registered nurses, we do not have a gross supply shortage in the state. We have a challenge of getting nurses to work in the settings where we need them and retaining them. We have really high rates of attrition and burnout. That's quite different from the set of challenges and the set of solutions we need to pursue for, let's say, primary care and behavioral health. So with that in mind, we've recently kicked off strategic planning processes for 2 areas of work in HCI's portfolio, behavioral health and nursing, the 2 highlighted on the left. I'll just say briefly, behavioral health, as you know, is the issue of the day. It's on the minds of providers, health workers, patients, health systems, and plans, and the administration. It's also an area where we are expecting significant state and federal resources for workforce development through the Behavioral Health Modernization via SB 326 and Proposition 1. And so we want to get ahead of those dollars by having a very clear picture of what are the biggest gaps, both in terms of geography, so looking at the county and region level, and by role. We have 15, 20, 25 types of providers that support behavioral health. Where are we facing the biggest gaps, and where do we target our dollars? Next slide, please. Our strategic planning work has 4 pillars, but 2 main pillars that I'll focus on, and The first of those is the classic strategic planning approach, where we're doing a landscape assessment, stakeholder consultations, and desk review to understand what the current challenges are, what's working well, what the state of the evidence is, and what interventions might not be evidenced but are promising. And then importantly, in parallel, we are conducting supply, demand, and pipeline modeling. This work is critical and will serve as the anchor of the strategy because it will allow us to more precisely pinpoint the problems that we are trying to solve. And then we can work backwards from those care gaps, those supply and demand gaps, to look back at the strategic planning work and say, what are the most promising interventions that we need to organize in concert to address these very specific gaps. Importantly, this work builds on the California Future Health Workforce Commission report that Catherine mentioned and goes further by comprehensively conducting supply and demand modeling for a complete set of roles in each area. So I mentioned we're doing this for behavioral health and nursing. We're looking at a list of about 8 to 12 roles in each of those categories and developing specific models and specific intervention sets for each. Next slide, please. I know we're short on time and folks are probably ready for lunch. Catherine also covered a lot of this, so I'll just kind of breeze through the findings from the early phase of our strategic planning process, which really just synthesizes some of the themes related to why we have shortages. So we have a first bucket around constraints to the pipeline and overall supply. A big challenge there is insufficient training capacity. Catherine mentioned that historically we've underinvested in training capacity, and that's an important factor. But really importantly, we are also constrained by faculty shortages and clinical placement shortages. This is very acute in the nursing space. So even if we had funding to expand nursing training as much as we needed in the state, we don't have enough faculty or nurses who are interested in being faculty, and we don't currently have enough spaces for clinical training of those nurses. So these are challenges we're really going to need to focus on in our strategic planning and our solutioning. The second piece is around kind of the increasing cost of training and therefore lower perceived return on investment for individuals thinking, should I pursue a career in health professions training? This is related to the first. So our public institutions are the most impacted. Catherine mentioned, I think it was 25% of qualified nursing applicants were accepted into nursing programs. It's the public programs at community colleges and CSUs that are most impacted. And so we are driving students to private institutions where they're paying higher tuitions and taking on more debt. And that, of course, relates to the second factor around lower perceived return on investment. And then we've also heard from health workers that there are a set of individual factors that make it challenging to train or to upgrade related to their personal circumstances. This too is constraining the pipeline. Next slide, please. The second set of sort of themes here that we'll highlight relates to challenges with retention in the workforce. So surveys in the last few years have shown that 30 to 35% of recently graduated nurses in California intended to leave the field within the next few years, even though they are recent graduates and recently have joined. So we have real challenges with retention, attrition, and burnout. Catherine already mentioned workplace conditions are part of the challenge here. It is physically, mentally, and emotionally demanding to be a healthcare provider, and that got worse during COVID. So we've seen a lot of exits from the field. Catherine also mentioned administrative burden. This comes up again and again with respondents. And then finally, pay and benefits is a significant issue for many. About 1 in 3 California nurses have cited pay and benefits as a factor that would drive their decision to leave their principal nursing position. In behavioral health, on average, mean wages are below California's average, and that's particularly true for the certified roles that are sort of the base of the workforce pyramid that we need to build in order to promote and prevent behavioral health issues. And then finally, this is also an equity issue. So we know HCI is particularly concerned with developing the workforce that serves our underserved communities, both geographically and folks who access care through Medi-Cal. And we know that those settings also often pay less than better resource settings that serve communities with better resources. Next slide, please. So looking ahead, we're thinking about how do we best target our funds and our resources? What are the biggest problems we want to solve? And I mentioned that supply and demand modeling is a major piece of this. I'll just walk through quickly what I mean by that. So with supply and demand modeling for health workforce, we're asking a couple of questions. What do we think the demand for services looks like now, but also will look like in the next 10 years? We know it takes years to develop a health workforce. Health workers don't grow on trees. It takes years for them to get through school. So we need to be looking ahead to what our future challenges are and making sure our investments now are getting us ahead of those future challenges. So we want to ask, what do we think demand for, let's say, behavioral health services will look like in 10 years? And how do we think that translates to specific health worker types? We also then need to look at supply. So if we take a look at current sort of output through training, but also supply in terms of in-migration, which Catherine touched on, if we take those trends and we sort of extrapolate them into the future, do we think those two lines are going to meet? Do we think our supply will meet demand? In most cases, the answer is going to be no. So then the question is, how big is that gap? For which roles and which regions of the state is that gap the biggest? And then what are the sort of sets of solutions that we need to leverage to close the gap? Next slide, please. I've already touched on this, but I think some of the things we're trying to do with this model is make sure that we have sort of a singular vision and a singular set of goals and objectives in this state for the way we move forward. We all have a role to play in workforce development, including purchasers, and it's important that we have a shared vision and a shared understanding of how we will make progress toward that vision. Next slide. And I just want to acknowledge that the work we're doing builds on a history of some supply and demand modeling in the state, but never before at this level of granularity in terms of sub-state and by role. So we're really adding something new here that I think is going to add a lot of value in the space. Next slide, please. That takes me to the question of use cases. We're really excited about this novel work at HCI and the value that it will add to our own lives. It will help us direct the funding that we have coming in. It will help us direct and coordinate with partners, but we really hope that the use cases go far beyond HCI and that this work is taken up by different partners in the space. There are too many use cases to name, but the idea is that we can use the data to drive a number of different applications by a number of different partners. And that takes me to my next slide, which is an attempt to map the many different players and partners who are working in this ecosystem. HCI is just one of those, and I mentioned before that we, of course, intend to use the results of this. Through Proposition 1 and a proposed federal match program, HCI will receive $2.4 billion to address behavioral health workforce development over the next 5 years. And we, of course, intend to use the results of this supply, demand, and strategic planning process to direct where best we use those dollars, and we hope to do that in partnership with other players. We'll get more out of our funds if we're working in lockstep with others. I'll also highlight some other use cases. HCI is a state institution, but there are a number of local institutions here in the ecosystem, and we hope that by doing county-level supply and demand modeling, we can help those local CBOs, workforce development boards, and counties understand their very specific gaps, which will vary across the state, and take action against those gaps to close those gaps themselves. Another use case that I love to highlight is a partnership with community colleges. Community colleges are one of the biggest trainers, if not the biggest trainer, of health workers in California. And the California community colleges have funding to support the expansion of their associate degree in nursing programs. And I'm really excited to share that they intend to use the results of our modeling exercise to determine where they expand. So historically, expansion of programs is driven by leadership and an anecdotal sense of demand, but it's not necessarily tied to where we know we will have workforce challenges in the future. And so we can really strategically expand our nursing programs at the community college level by using these results to determine where they open and expand their associate degree in nursing programs. Finally, for this audience, purchasers may be notably absent from the graphic, but of course you have a role to play in workforce development. One example that I can share of the role that purchasers can play in supporting workforce development is with Covered California. As you may know, Covered California, CalPERS, and DHCS have aligned on a small number of clinically important measures, and each attached direct and substantial financial incentives to health plan improvement based on those measures. Covered California has taken the additional step of committing their Quality Transformation Initiative funds for population health investments, which includes an exploration of working with us at HCI to fund our health professions career opportunity programs, which drive the expansion of a diverse pipeline of youth and young adults interested in health professions training. With our forthcoming strategy, we will be able to indicate to covered California, where we see the greatest gaps and where we need to focus on pipeline development, which communities and which geographies. Next slide, please. Finally, that gets me to the question that was posed to both of us before this session, which is what can CalPERS do to influence health workforce development? I'll offer some food for thought, as Catherine did, and then we're happy to take questions, comments, and reactions. Two sort of broad buckets here, and the first is through the role as a purchaser with direct influence on payers and health systems. So through contract negotiations and contractual language, there are a number of different good practices that could be incentivized, supported, and enforced. I'm going to focus on the suggestion D, which is to require adoption of outcome-based alternative payment models. We know that quality-linked alternative payment models, or APMs, can improve health outcomes, cut costs, and better incentivize team-based care. They do this in part by encouraging a shift of clinical tasks from clinicians to other qualified staff through bundled or capitated payment models. In a study of 4 healthcare systems using APMs, low complexity care coordination tasks were shifted to licensed practical nurses, medical assistants, and other unlicensed personnel, allowing registered nurses and social workers to practice at the top of their licenses and focus on more complex cases. It's notable that these shifts required substantial on-the-job training investment, which can also be influenced through contractual language, encouraging plans and systems to grow their own, to invest in the professional development of their own workforce and keep those workers where they are needed. The second category of suggestions here is just around data sharing. So as you've heard today, we will be more than happy to share the results of our supply and demand modeling to highlight which counties are facing the most severe shortages for behavioral health and nursing over the next 10 years. And then we hope in turn that some of our partners will share with us any of the data they have that help us better understand where we're facing gaps, where we're seeing issues with workforce access. And with that, I'll pause and open for questions, comments.
Okay, thank you very much. So great presentations on both your parts. I am going to go back to the people that had questions and then move on to if we have additional questions. So Kevin.
Thank you. Let me start off by saying I come from a community college where we profusely brag about our paramedic program and our nursing program. So I'm going to leave my bias out. There was a slide in the first presentation that 25% of qualified applicants for bachelor's of nursing programs could be enrolled in 21, 22. Has that number changed in 22, 23 and moving forward? Or is that a cohort issue that needs to be looked at in possibly expanding cohorts?
I don't have data available for 22, 23. I don't know if that's been published yet. I'm happy to check and get back to you. It was not a one-time cohort issue. Like, it was a lot better the year before. It has gotten worse over time. I think the issue that Libby brought up of lack of faculty is absolutely a factor. And as we've seen both the aging workforce dynamic in nursing and COVID effects, we've seen, drop off in faculty as well. So I don't know off the top of my head, like what the trend rate was for the 10 years, but it was not a one-time like bad blip. It's been low for some time. It has gotten worse.
Thank you.
That's it? Okay. Lisa.
All right, thank you. Thank you for the presentation. What I was struck by is the overwhelming need here in California for us to increase the number of seats that we have in our medical schools and all of our nursing schools and various healthcare professions. And I am not seeing that kind of commitment from the community colleges, the UCs, and the CSUs that are needed to be able to meet the demand that's coming. The question is, what can we do to make it more public as to what the crying need is for us to increase the number of places that we have where students can go.
So it's a great question. Agree with your assessment 110%. And I think it requires a couple of different angles in. There is absolutely a need to expand medical education. That means expanding the footprint of the UC system. There is a new UCSF Merced campus. There was a planning grant. There's an initial building. Funding is needed to continue that effort, but that's a start. We need more than that. So there's that advocacy effort. California is unique in that only the UC system provides medical education. In most other states, or at least in many other states, the state university system also has a medical school. That's key to expanding footprint and geographic access. There has been, historic agreements that only the UC can operate a medical school. I think given the crisis, that's being rethought, and there are some advocacy efforts there. Could CSU open up its own medical school? That doesn't change the funding. More funding is still needed from the state to make it happen, but that's a slightly different angle on it. When it comes to nursing, I think there's a couple of different things to consider. The data I gave was on bachelors of nursing. There are major efforts to expand associate degrees, and there's an outstanding question: does every RN need to have a bachelor's degree to begin with? That's a real limiter in terms of diversity and representation, both in terms of race, ethnicity, and age. People mid-career are very reluctant to go back and get a bachelor's degree. So in terms of upskilling, that's a deterrent. Other states are looking at that and relaxing and or changing their rules to remove that. So that would be another sort of angle into it. But at the end of the day, the state needs to devote more funds to education, and the state educational institutions need to devote more of their funding to health.
Is that it, Lisa? All right, Melissa.
Thank you for your presentation. It's my understanding that the federally qualified health centers make up one of the largest healthcare systems here in California. If you were to put them together, and they would serve over 7 million Californians, predominantly in rural and underserved areas in California. And I think following the same trend, as you pointed out in those two presentations, the FQHCs face catastrophic staffing shortages, unprecedented turnover, and they chronically struggle to properly train workers, which really undermines the care for those underserved communities. But the frontline workers I've spoken to from FQHCs have voiced concerns that they don't have a seat at the table. And when some clinic workers have spoken out about the unfair treatment that they receive in those clinics, they face retaliation, and some have even lost their job. I think the workers' unique expertise could help identify and inform long-term solutions to the crises confronting clinics and the overall well-being of healthcare in California. Are you looking at addressing some of the employers' unproductive and anti-union practices?
I'm happy to take that, and the short answer is that's outside the remit of HCI. That would fall under Labor and Workforce Development Agency, so it's an important issue that you've raised.
We can't hear you. You have to lean towards the mic.
I think I just need to lean more. Okay, let me try that again. Appreciate the issue that you've raised, and I was saying the short answer is that for HCI, that's outside the remit of what we work on. I do believe that would be under the Labor Workforce Development Agency. There are advocacy organizations, such as the California Primary Care Association, that I think would be the appropriate avenue for some of that advocacy, and probably through unions as well.
Sure. So, thank you. On the second presentation, the HCI presentation, page 6, you identified the 6 guiding principles, and then an aspirational principle is to center the worker in this work. And it seems really illogical to me to try to address a problem like workforce development challenges without thinking about hearing from, talking to, and learning from the workforce. So I just want to say I encourage HCI to turn this from an aspirational principle to an established principle.
Yeah, I appreciate that comment, and I would just say it's aspirational because I'll be honest with you, I think it would be newer for us to do that truly at a level of depth that I think the issue requires. So it is something we're committed to, and this just signals that it will be new for us compared to some of our commitments in the past. I appreciate you raising it up.
Yeah, you're still talking quietly.
Okay,
That-
I'll lean in more next time.
And I think I want to make sure that's the end of the questions. But I had a comment as well. So when it comes to the workforce itself, so as it is, the state of California, counties, have a hard time staffing because we don't pay as well as, say, a UC system or a private hospital or wherever, right? So how do we, I mean, you're talking about how the state has to fund all of this, right? The education, et cetera. Is that the main source of income we're looking for to get this, to stopgap this loss of employees?
So I would argue that actually this state is not the primary source. We will have significant resources. Let's take behavioral health. We'll have $2.4 billion, as I mentioned, through the Proposition 1 and federal match funding. But counties will also have their own resources that are separate from the state funds related to county workforce development. And so they can also leverage those resources. Catherine mentioned that there are a number of different actors, I would assume philanthropy and others, who are supporting stipends, hiring bonuses, recruitment bonuses, sort of top-ups that can be used to attract folks to underserved settings and to counties and CBOs that are facing recruitment challenges. So I would just underscore kind of the message here, which is it's no single player in the space. It's going to require all of us to sort of organize around what are the challenges and what are the different kinds of solutions that we can pursue.
And I think I'll just comment back to what Ms. Walker said, which is we have underinvested for so long, and we've continued to increase the cost of the education to such a degree. And I have to tell you a little anecdote. I took an Uber, Lyft, whatever, home from the airport, and it was a resident at UC Davis Medical Center driving me because he didn't make enough money as a resident.
It's telling. I just wanted to add one comment. We've talked a lot about the state's role in paying for the education and training of healthcare providers. The other thing to think about is the role of the delivery system in paying healthcare workers.
Yes.
The Office of Healthcare Affordability is in the midst this summer of passing its rules on primary care investment, and next year we'll do the same for behavioral health investment. And those will be new requirements for health plans of all types, commercial, Medi-Cal, et cetera, in the state, to publicly report what it is they are spending on primary care. And it will include a target. The proposed target for primary care is 15%. The behavioral health target, again, will be set next year. The idea being that plans have also underinvested in paying primary care providers, primary care nurses, primary care services, primary care community health workers, primary care doulas, et cetera. And this will provide an incentive through transparent reporting and, again, a target. So that should also help with some of the income disparities that we see primary care and behavioral health to specialty, that will help with sort of well-being and retention, and long-term also make those fields more attractive and more supportive.
I appreciate it. This was a great presentation. It's sort of depressing because you pretty much told us that we have not enough doctors and nurses. But thank you very much. It was very edifying. And I don't think I had any more questions. And I think I had no public comment. I think questions got answered as they were coming up with public comments. So we are at 12:42. We have to be back in here at 1:40 for our next session because we are time certain at 1:45. So David is going to lead you as I will be going. So
He was thinking to do a short lunch, a 30-minute lunch. Let Julie get started.
you really want to do that? All right, you can do that. All right, so half an hour lunch till 1:15.
Thank you.
Otherwise, we'll be.
Thanks, you guys.
First, to advance clinical quality improvements that will enhance members' health outcomes with a special focus on advancing equitable care. Secondly, to get an update on the work being done with our health partners to enhance behavioral health services. Presenting are Don Molds, our Chief Health Director, and Dr. Julia Logan, our Chief Medical Officer. Mr. Molds, please get us started.
And I will get us started by turning things over to Dr. Logan with great appreciation.
Thank you. And Mr. Miller, do I have the first half hour, correct? And then we're pausing the health program?
So, Julia, you can go until 1:45. We have
Okay.
a time certain speaker coming in.
Okay.
And then we can take a bit of an intermission and then have you finish your remaining half an hour.
Great.
That
Perfect.
works?
Thank you so much.
Thank you.
Okay. So, good afternoon, Mr. Miller and members of the board. Julia Logan from the CalPERS Health Team. It's really nice to be here talking with you all again. Today I'm going to provide you details on a few topics that really impact our members. First, our quality and equity approach that I'm proud to say now encompasses both our HMOs and our PPOs. And second, I'll provide an update on our continued work to improve access and quality of behavioral health services for our members. I will note that some of this information is not new to you all. We've had discussions about this before, but my intent with this talk is to really give you more detail and texture and demonstrate how we're moving forward across our entire program with quality and equity. I always like to set the stage with this graphic. At CalPERS, as you know, our strategic goal for health is to provide exceptional health care for all our members. This means that our members are at the center of everything we do and every decision we make. As you know, we've significantly refined our approach to quality in our new HMO and PPO contracts. First, we narrowed the list of measures that our health plans must report on to a small set of high-impact population health-centered measures. By doing this, we're focusing on and enabling our plans and providers to focus on measures that count and measures that are really meaningful. I'll talk about what these specific measures are shortly. Second, we've increased the benchmark that plans must hit for each of these measures to drive real improvements in care. We also have significantly increased the financial penalties that plans must pay if they fail to hit that benchmark, and this strengthens accountability. Third, we've done all of this in partnership with our other major public purchasers in the state to magnify the impact of this change. The providers in our network treat CalPERS patients as well as covered California patients and Medi-Cal patients. Clinicians do not differentiate their treatment of patients based on insurance. So if the goals are the same for all purchasers and all providers, it helps to improve the results for everyone in California, including our members. Finally, we have also focused a lot of our work on identifying health disparities with the ultimate goal of eliminating those disparities, which I'll talk more about shortly. While our quality alignment measure set is what we tend to talk about the most when we discuss how we measure and monitor quality, I wanted to mention that we're assessing quality in a number of different ways. All of our plans, HMOs and PPOs, continue to report on the rate of C-sections for healthy, full-term, first-time pregnancies, and we've set a national benchmark for that one. We've also created a quality floor for our plans, requiring them to maintain an NCQA health plan rating of at least 3. So that's 3 on a scale of 0 to 5. That rating is a composite of the results of quality measures, member experience scores, and their accreditation results. Finally, because members' experience of their own health care is so important, as we talk about, we also hold our health plans accountable to a benchmark on patient experience as well. This slide outlines our focused list of quality measures that count. And you've heard us talk about them before, but I wanted to give you more of the why behind these measures. The first is childhood immunizations. No child should have to die from a preventable disease. and immunizations are some of the most cost-effective interventions that we have in medicine. For every dollar spent on getting vaccinated, $29 can be saved in indirect or direct care costs. Next is colorectal cancer screening. After lung cancer, colon cancer is the second leading cause of cancer death in the United States. And I think most of us have heard about the rising rates in younger people. Screening reduces the risk of developing and dying from colorectal cancer by 60 to 70%. Next, we have measures to monitor the control of high blood pressure and diabetes. These are two of the most common chronic diseases nationally and for CalPERS members as well. And if left uncontrolled, both can lead to a host of debilitating and life-threatening conditions. Finally, timely and adequate prenatal and postpartum care can set the stage for the long-term health and well-being of our moms and babies in CalPERS. We also have 2 behavioral health measures that the plans are reporting on because it's so critical we gather information on mental health screening and treatment of substance use disorders. Due to issues around reporting on these relatively new measures and very new benchmarks, we're not yet holding plans accountable to a benchmark, but plan to do so in the future. So what's the impact of these changes that we've made for the HMOs and PPOs, and how will the adoption of these measures really drive improvements? Previously, our health plans had to hit the 50th percentile as their benchmark or improve year over year by 3% for that measure. But now we've raised the benchmark to 66% and removed the 3% improvement. So simply they have to hit that new benchmark. Additionally, in prior years, when plans didn't meet the benchmark, they were fined a small percentage of their administrative services fee, so that the amount of money at risk for the quality measure was fairly low, really small enough to be considered just another cost of doing business for the plans, but not a powerful motivator to improve on performance. Now the plans have a far more significant amount of money at risk on these measures. The money at risk starts at 1% of premium and increases to 4% of premium by year 4 for the HMO plans, and the amount at risk for the PPOs is a much higher percentage of their fees. This equates to a vastly increased amount of money tied to performance for these measures. The graph illustrated here on the left is a pictorial representation of what the payment will be for the HMOs and PPOs depending on where plan performance falls for that measure. For plans that hit the benchmark, which is the 66th percentile, which I mentioned, they will pay nothing for that measure, as you see on the far right, 0% payment at the 66th. For plans that don't hit the benchmark, there's a graded payment scale. It's based on a sliding scale, so plans pay more closer they are to the 25th, and pay less the closer they are to the 66th, which is what the green line represents. Plans that perform below the 25th percentile for a measure will pay the full amount for that measure and will be required to implement a quality improvement plan in consultation with CalPERS. For the HMOs, these payments will be first assessed next year based on their performance this year, and for the PPOs, payments will be first assessed in 2026. As a final comment on our quality approach, I wanted to show you the extent of the collaboration and alignment that has gone into developing this quality improvement strategy. As you can see on this admittedly busy slide, CalPERS, Covered California, DHCS, and the Department of Managed Healthcare, DMHC, have all united on the choice of measures. Additionally, all public purchasers have significantly increased the amount of money that the plans have at risk on these measures, and all entities have increased the benchmark or threshold that the plans must achieve. This obviously has been a very deliberate effort by the major healthcare entities in California to drive improvements in care while reducing the administrative reporting burden on providers and plans, which we heard in the last conversation that was a really important piece of the workforce. Okay, let's shift and talk about our approach to equity. First, I want to share a high-level preview of our disparity elimination work with our quality measures, which aligns again with our purchaser partners. Health plans will be breaking down our quality alignment measures by race and ethnicity so that we can understand where disparities exist in our population, and we will tie financial accountability for eliminating these disparities. Plans will need to meet the 66th percentile for each racial and ethnic group, which we call subpopulations. There will be a minimum denominator requirement for each subpopulation so we can have meaningful and actionable results. Covered California has done some very thoughtful work in this space, and we've incorporated that into our approach. They've engaged health equity experts to understand the minimum sample size required for results that are complete and accurate. They learned that it's challenging to find meaningful differences in performance when you stratify by race and ethnicity and have low denominator sizes. With small populations, we don't necessarily know if the difference we see are real differences, as in a difference in the care received, or differences due to chance, and we're aligning with Covered California as we refine our methodology. Next, I wanted to give you an update on other aspects of our comprehensive approach to eliminate disparities, starting with our focus on primary care. As you know, we're committed to ensuring that all of our members, HMO and PPO, are linked to high-quality primary care clinicians to create stable primary care relationships, be engaged more deeply in their healthcare decisions, and establish a foundation of trust that promotes continuity of care. As you know, there's strong evidence, and we've talked about this, that highly continuous primary care relationships improve outcomes, improve the use of preventive services, decrease overall healthcare expenditures, and decrease inequities. Our contracts require that our health plans have a comprehensive disparity elimination plan, a member advisory committee, and a cultural and linguistic program. We want our members to have a voice in their care, so we're working with our health plans to maintain member advisory committees that reflect our diverse membership. Many plans are offering financial incentives to members who participate on these committees to compensate them for their time so they can afford to take time out of their busy day to share their thoughts with plans. And this also ensures that the committees can be representative and include members who may not be able to participate otherwise. Plans are required to implement cultural and linguistic programs, which include trainings that adhere to national standards and ensure that network providers and health plan staff receive cultural competency, diversity, equity, and inclusion training. Many of our plans have reported that they've implemented these trainings, especially related to gender-affirming care and cultural competency. Other plans have launched culturally focused campaigns to increase preventive care screenings in specific populations. So I've laid out this quality and equity plan to eliminate disparities, and so I just wanted to let you know what we think success will look like. First, all members will receive high-quality care. Second, we, meaning CalPERS and our health plan partners, will embrace an equity-centered approach to meet the diverse needs of our members. Third, we expect greater accountability for improving quality for all populations and subpopulations, especially those least served by current quality improvement approaches. And this accountability includes quality improvement plans, public reporting, and financial accountability. And last, we expect from ourselves deep engagement and monitoring to make sure that we're moving in the right direction. So that ends the quality and equity part of my presentation, and I'm happy to pause for questions here.
Thank you, Dr. Logan. I do have a question. I guess a comment question. If we're hoping to move people up to kind of the 66th percentile, is the expectation that over time, as they rise to meet that challenge, we would then ultimately say move to the top quartile? Will we be reassessing and reestablishing and moving the target on them to help them continue to improve their excellence?
You are speaking my language, Mr. Miller. Yes, absolutely. That is a point in time in terms of where we hope the plans will be. We monitor all of the quality measures to see where they're going, and if all plans are hitting those targets, we will certainly be moving the target upward.
Excellent. Question?
Can I-
Oh, Don?
Julie, do you mind if I jump in for
No,
1
please.
I'll just add, so we have in fact have been having this conversation quite a bit. The goal will be to bring them up. When that becomes a new normal, there's still room for improvement. At some point, we do not expect to be doing this within single contract cycles, but in future contract cycles, we may decide, because in California everybody is doing the things that we want them to be doing now that they are not doing at the rate that we hope, that there are other targets, there are other goals in improving health. So we could conceivably see improvements so vast and significant in areas like blood pressure control or colorectal cancer screening that as we are thinking about how to make our population healthier over time, we would focus on those because those become the most beneficial targets to focus on. So that's the other trajectory of this, but we have set, Dr. Logan and our colleagues at CoverIT and DHCS have set ambitious targets that are not going to be accomplished overnight. We're seeing a lot of progress, changes in the market, et cetera. But at some point in the future, we hope to be able to migrate to other key targets.
Yeah, very good. Yeah, it seems to me that flexibility of evolving both your targets and what levels they're set at to get to, if you're an airline, the 96th percentile may not be so great. Could mean a lot of planes hitting the ground. So yeah, I really appreciate the quantitative approach, the fact-based approach. If we're going to be trying to move people more to evidence-based medicine and these models, it behooves us to be kind of taking a more evidence-based factual approach, and I for one am glad to see it. Any questions from board members? Questions, comments? Okay. Seeing none, I don't think we have enough time to get far into the behavioral health service update. We'll do that. We'll revisit that because we've got an item coming up time certain. Let's see, what time is it? In a few minutes. Oh, okay, so we can move on. With that being time certain, can we move on to it now?
Yep.
Okay, great. Okay, so I will get my little. So we're now going to kind of move in a completely different direction, away from healthcare and back to investments. So we're very pleased to have with us Jim Coulter, the founding partner and executive chairman of TPG. He's here to lead us in what I'm sure will be an insightful discussion about private equity and its role in helping to finance the global climate transition. And we're glad to have Mr. Coulter with us, and I'll kick it over to Mr. Gilmore. Do you want to any introductory words? Nope. Okay. So, okay. So where is Mr. Oh, okay. Okay, so we'll.
They're just getting.
Oh, okay. And is he going to be over at the table?
Yeah. Yeah.
Okay. Okay. Welcome, Mr. Coulter. We're really happy that you could be with us, and I will hand the floor to you at this point.
Thank you. It's a pleasure to be here, but somehow I grabbed the middle of the afternoon low point of the day slot. So today we're going to try to do something totally different. I have a bunch of slides. We're going to use some of them, not use them. I'm going to have a conversation, and I'm going to do it at the request of your team. As many of you may know, I'm the co-founder, executive chairman of TPG, one of your GP partners and a longtime player in the private equity industry. And as well as building an organization that is designed to deliver returns, it turned out over the years that we have a very interesting seat in the world of business, where we get to see companies come through, we own them, we say no to some, we help them grow. And that seat not only drives returns, it drives insight about what's happening in the world. Each year we get together and we think about not our pitch for what we're doing, but what that ecosystem is telling us about the world, and then we share it with our LPs. Your team found two of the topics that we shared this year interesting, so they asked me to bring it into this room. And they're topics I think that hopefully will generate some thought, but also will be aligned with where you as a board are taking this important institution. The first topic is a view from the front lines of climate investing. When I meet someone from the services, from the armed services, I always say, thank you for your service. I'd like to, for this board, say thank you for your leadership on this. It has caught our attention. It's caught the attention of the market, what you're doing. You're on one end of the ecosystem where you're generating capital. My job is to put that capital to work. And I want to give you a view from how that's working. Just to give you a sense from it, I think today there are three big themes in investing. AI, we're only going to talk about that if you want to talk about it, but it uses a ton of power. If you do an AI search, it's 10 times more power consumptive than a Google search, but it's a important part of the economy. But I'm going to focus on where we're spending a lot of our time, which is decarbonization, $150 trillion reindustrialization of the world. And interestingly enough, it's happening at the same time as deglobalization. So we're rebuilding supply chains and we're rebuilding them at home here in California and around the country. My role in that is, it's something we've been working on for a long time. In 2016, we founded the largest impact fund platform. One of our sectors was decarbonization. By 2020, it was clear that was going to be a lot bigger than online ed. So we created TPG Rise Climate. Hank Paulson joined me to run it. I run it personally. It's the largest fund of its type, doing private equity and creating decarbonization solutions. We're joined by 28 of the largest corporations in the world, from Google to Apple to Boeing to 3M to GM to GE. And we've been investing across the world since then. Just to give you a sense of what that looks like today, our portfolio is built from over 1,400 climate deals we've looked at. We've already had 2 IPOs. Actually, we signed up 2 deals last week, so it's now 25 companies. And its returns, full returns, and impact. This portfolio so far is the equivalent of taking 180 million cars off the road. So this is about putting money to work to drive solutions. You know, you never really capture it in PowerPoint, so let me just give you like 30 seconds on what it looks like every day when I walk in the office. We're the largest rooftop solar player in Europe. We are doing the largest carbon capture project in the US. We are the largest producers of EVs in India. We are building a plant to do electric airplanes, just FAA certified, in Burlington, Vermont. We are here in California building the leader in sustainable aviation fuel, a company called 12. We are saving lives and delivering emissions-free medical supplies across Africa in a company called Zipline. We are in Arkansas building a low carbon steel plant that does rebar. We are the largest producer of carbon credits in the US. We are in West Virginia building a battery plant that produces storage at 1/10 the cost of lithium ion. Around the world, we're enabling hydrogen projects through a company called Omium. We are here in California delivering renewable natural gas through Olympus Terminals. We're measuring renewable fuels around the world, which you have to do to actually make sure they're renewable. We are running a 7 million acre or 6 million acre carbon sink in Africa as an ecotourism company. We are here in California doing solar trackers, and we are one of the largest producers of storage and clean power here in California and in Texas. You're not going to hear a lot more about what we're else doing. I just want to give you a sense about what it looks like on the front lines. And a lot of that is in California. Not only have you been a leader in the capital to this, California has been a leader. I want to talk to you later about the California model for how we think about this. The other topic, we're going to let you choose what you want to talk about there, Marcy, but the other topic is private equity. And you are very well advised on private equity. There's plenty of consultants. But last year on the 30th anniversary of TPG, I did a personal practitioner's view. When I watch Wimbledon, I like to see Chrissy Everett and John McEnroe. I like to see Tony Romo. And you want someone in the booth who has played the game. So you have lots of people who can tell you about private equity. I'm going to give you a slightly different view, observations from someone who's played the game for 30 years. It turns out I'm maybe the youngest of the first generation in private equity. It means I'm 10 years too young to run for president, but I've got enough gray hair to tell you that I can maybe give you a little bit of perspective. Perspective is enormously important right now. This industry has gotten to a point that we had no idea. None of us understood how big it would be. And yet, if you look at the numbers today, it's at one of those moments as it gets from time to time where there's lots of questions about it. My personal history in that, I first ran into private equity in 1982. Man, am I dating myself here? I used to do private equity models with an HP 12C and a handwritten spreadsheet. I was there at the first use of junk bonds for a large takeover. I then, after business school here in California, went to work for a family. This was before private equity had a name. And then since 1992, I've been building TPG from 3 people and $64 million of AUM to 1,900 people and $224 billion of AUM. And wow, there's some stories there for another day. So those are the 2 topics that you guys can choose among, both of which your team thought might be of interest to you. And the way we're going to do this is, these are both so big and confusing that when I write speeches about them, I always have this, I still do this. I put up sticky notes, here are the things that are interesting to me. And when you get into these topics, I couldn't make any hide nor hair of the sticky notes. So essentially, I'm just going to give you the topics. We have 12 modules here. We'll probably get through 6 to 8 of them. But I want to do the speech you want to do, not something that I dreamed up last night. And let me just give you what the modules are. Marcy, I'm going to make you pick a couple here, but from the climate ecosystem, it's the missing middle. Why do you not want to do venture in climate, in my view? Secondly, green shoots. I'm actually going to bring some optimism into the climate discussion. Lithium Valley, there is no Silicon Valley in climate. Where is Lithium Valley? The policy box, how should you think about the IRA and the other policies out there? They are now industrial policy, and that's really important. Passing the baton, it's a new era. And whataboutisms. We can't fall for whataboutisms in climate. And then on the private equity side, to understand climate today, you have to understand Mark Twain and Rube Goldberg. The surprise of size, this industry is so much bigger than we ever expected it to be. Why is that? And where might it go from here? The power of prehistory, what you decide in this room will echo for decades, and understanding why that's so. Something I know is deeply important to this group, which is how do you practice private equity responsibly? Why have we gotten it wrong sometimes as an industry? Where have we gotten it right? Time-lapse volatility. Anton Thomas, your team have a hard time because this industry is much more volatile than people think, and I want to talk about that. And lastly, private equity is about who's in the room and how they operate. So the human capital equation is important. Again, you'll get to choose which topics. Marcy, just to get us off on the right foot here, we can either do climate, I want to do green shoots there, or if you want to start on private equity, either we can do history, what does history tell us about today, or we can talk about today, which would be Mark Twain and Rube Goldberg.
So I agree with you on the green shoots. It's good to look at opportunities and focus more on the path ahead of us. But I also think we should talk about either human capital or responsible private equity.
Great. Where would you like to start? Green shoots. Should we get a little optimism going?
Let's start with optimism.
All right.
Okay.
Climate investing is hard, which is why you need to specialize and think about it. And climate investing and tech investing have one thing in common: lots of conferences, huge number, same hotels, same bad coffee, lots of conferences, but they sound very different. So this is a word cloud from, this is a word cloud from a climate conference I went to recently, all sorts of problems, unproven technology, permitting delays, et cetera. And when I listen to that, I find myself agreeing with all of them, but saying yes, but. Sometimes you have to go just a little bit deeper. And what you find in climate, and I would suggest this to you as a board, is occasionally you have to channel your inner tech. So let's think about what a tech conference sounds like.
But I'm genuinely optimistic about work in the metaverse. Whether as a hologram sitting next to you in a physical meeting or in a discussion taking place in the metaverse,
I think this technology is inevitable. I think this is the future of the internet. So I think over time you will see greater and greater acceptance.
We believe that AI will be about individual empowerment and agency at a scale that we've never seen before, and that will elevate humanity to a scale that we've never seen before either.
We'll be able to create a theory of the entire universe.
Tesla car next year will probably be 90%
2014
capable of autopilot.
I'm extremely confident of achieving full autonomy and releasing it to the Tesla customer base next year.
Essentially, the voice of text is the voice of optimism. Everything can be done tomorrow. Everything will be delivered. I love Musk saying, he plans to die on Mars, just not an impact. The most famous voices in tech are voices of optimism. Climate conferences sound a little differently for good reason, but I want you to think about the sound.
Ravaged by rising seas, deadly superstorms, devastating droughts.
Entire ecosystems are collapsing. We are in the beginning of a mass extinction.
Both ends of our planet right now, we're seeing signs of distress.
We have silicon shortage today, and then just electricity shortages in general in about 2 years.
When Musk moves from a tech conference to a climate conference, he gets pessimistic. These are incredibly important voices, and they're calling out a crisis. But if you are going to do something, you have to begin by believing you can do it. So both tech conferences, frankly, and climate conferences drive me a little crazy. I'm a pragmatist. We need to find a way to get this done. So let me tell you some of the optimism I see when I'm on the front lines. First of all, expect discontinuities. The whole question of net zero, Marcia, this is something you've dealt with. What is net zero and how do you get there? The scientists have helped define it, but recently SBTI, which is the NGO which talks about net zero, has given us the path for net zero. And you can read it yourself, but just quickly, the minimum forward-looking ambition of near-term targets is consistent with reaching net zero by 2050, assuming linear. First of all, this is great science, but I've been in business 40 years, nothing is linear, and I'm not sure what to do with it. What I think we can do is we can get a little optimistic by knowing that it will not be linear. The way business works is discontinuities. Think about the oil business. The oil business was pretty slow until something called Spindletop happened, and we understood geologies differently, and the industry popped 20% in a year or two. It then flattened out until we understood that we could find oil in other places than the US, and we could find oil offshore. And by 1976, we had pretty much decided that we could not solve the oil problem. And the general belief was this.
And so here's where we were.
That scale at the bottom, the top of the curve is about 2000.
Right up to about here. And the estimated peak would occur about 1995, and we go into decline.
We need to have a realization that we've got about 35 years worth of oil left in the whole world. We're going to run out of oil.
Now, these were important understandings, but sometimes we fail to understand how we will adapt to problems. And what often solves the problem is discontinuities. And industries are full of discontinuities. For oil, it was fracking. But if you look at other industries, trading, indexing, changed trading, Uber changed taxis. And as I travel this industry day to day, there are multiple discontinuities in climate lurking out there. Fusion, fission, natural hydrogen, global carbon markets, direct air camps, biochar, fracking. I'm not sure which of these yet will help us solve the problem, but I would bet on the field. I would bet on the field. Second piece of optimism is cost curves. We all understand cost curves. Things get cheaper as we do more of them, but what we don't understand is at some point, the cost curves hit a level where everything changes. So airline cost curves came down for a while until suddenly we hit that moment where Ryanair in Europe and Southwest in the US made sense and we quintupled air travel in a decade. Cell phones were a rarity in the developed markets until about 2000, and we hit a point and now it's a ubiquity. I don't know if you've been to Africa recently, but everything runs on cell phones. And video conferencing was actually invented in 1964. It cost $5,300 an hour. No one cared. But when it gets near free, we have Zoom. Across the, next slide please, across the climate world, there is a massive set of cost curves happening. Massive set of cost curves. Solar was 5 times more expensive than coal maybe 12 years ago. Today, it's 50% cheaper than coal. And that's happening around the world. 82% lower battery cost packs than 10 years ago. This gives me optimism. Actually, fossil fuels have been flat in real cost for a long, long time. Solar is getting better and better. All of you should read this article from The Economist about 2 weeks ago, beginning to understand the power of cost curves within renewable energy. And finally, on the point of optimism, we are luckily good at calling out problems. We sometimes underestimate, and we're not as good as understanding our ability to solve them when we get our action and our intent together. I don't know if any of you remember a book called The Population Bomb. It was one of the most popular books in the late 60s, and it pointed out problems we had in feeding the world, literally. It predicted hundreds of millions of people would starve to death over the next decade. Didn't happen. It wasn't that the problem wasn't there. It was that we didn't understand the forward movement in food systems, seeds, et cetera. Los Angeles was going to be a dystopian, end of the world place in smog. Last time I was there, the sky was free. And recently, the ozone layer is closing because of action we took around hydrofluorocarbons, et cetera. My point is, I get a little more optimistic when I see things moving together, and we have to understand that motion. Your actions in this area are deeply important because capital is the feedstock of this forward movement. And on the ground, it's interesting. I sometimes don't pick this up at conferences, but this is Bloomberg as of 2017 predicting how solar and EVs would move by 2030. And this was the curve they drew, pretty big growth. But by 2020, they had to draw the curve again because they were way ahead. And by 2022, they had to draw the curve again because they were way ahead. So over and over again, we've underestimated the power of forward movement. We may not be moving fast enough, but we're moving faster. And so, one of my favorite set of leadership quotes is from Colin Powell. And so we can shake a stick at this problem, but leadership, and I think this board is showing leadership, is about solving the problem. And we need to have just a touch. We need to understand the crisis, but we have to have a little bit of optimism because Colin Powell said optimism is a force multiplier. So long way to travel, but some green shoots. I want to can I talk about the little power of prehistory in private equity? Do you want to talk about that? Or Marcy, you want us to go right to human capital? Because I think actually you need to understand the prehistory to kind of understand the problem of human capital today.
Yeah, I think if you believe it's important to set the stage in that way, but I think for this board, the responsible private equity along with human capital. And then if you have time, we do have a board member who had expressed interest in how AI is going to impact the private equity industry as well.
AI is going to impact everything industries, right? Absolutely. So first of all, power of prehistory, because it's not very often that you have someone in the room that was there at the creation. So kind of understanding where it went. And I'm wrong to say I was there at the creation, because I'm often asked, like, where did private equity start? As an investor, I read enormous amounts of history, because if you're a long-term investor, you have to kind of develop pattern recognition over long periods of time. So I read biographies. And if you look at Andrew Carnegie or JP Morgan, what they did was private equity. Andrew Carnegie built US Steel as a roll-up of steel plants in the late 1800s. So private equity has been around forever. JP Morgan started AT&T, as a private equity investment. But the industry, as you know it, began to start in the 70s with a couple of, you'll recognize a number of these names, which is, not many industries you recognize the names 60 years later. And these were tiny companies, Warburg Pincus or KKR, $24 million. But they were the beginning of an industry that you're now a pillar in, which didn't have a name then, but now called private equity. There were a few seminal moments along the way. So first of all, it turns out Garfield the cat was incredibly important in private equity. So one of the early firms in private equity was Westray. It was a company started by William Simon. And they did a deal to buy a greeting card company called Gibson Greetings. They paid $80 million. They put in $1 million of equity. And then 2 years, they signed Garfield the cat, took off, and 2 years later, they sold it for $240 million, making 200 times their money in 2 years. And then they did the unthinkable. They reported that to the press. And so suddenly people woke up and said, wait a second, what is this idea that you can buy a company for not much money? The second thing that happened in this time frame is the invention of junk bonds. And junk bonds created a part of the capital structure that allowed more companies to be bought, like Gibson Greetings. This caught a lot of people's attention. So the next thing that happened was a lot of other people on Wall Street figured this out. And Marcy, this is why I wanted to set up. These decisions, Wall Street was dramatically white and male. And that's where the industry started. And this is an industry that moves slowly on these areas, and I'm embarrassed about that, but frankly, that is where it started. And these are names still out there, but not particularly large funds. And these are things that are still in your portfolio, decades later. We then hit the second seminal moment, and that was RGR Nabisco. Some of you may have heard of this transaction. The reason it was a seminal moment is the middle slide here, which is, it was a $25 billion deal at that point. In today's dollars, that would be almost $1 trillion deal. Imagine like $1 trillion deal with a bunch of people no one had ever heard of before. And there were books written about it. Barbarians at the Gate. I love the name, Barbarians at the Gate. And then perhaps more dangerously, there was a mini-series about it. So no one had ever heard of this thing called private equity. Let me show you how it was introduced to people. So first of all, I sort of laugh when I look at this, because it has been a long time since I've been negotiating a deal around a candelabra. I can't, I found out I didn't have to wear a tie today. I was happy because I don't know if I'd find it, and I don't own cufflinks anymore. Like this, think about this as a scene. And it's really a terrible movie, but let me give you a sense of what it sounds like.
Oh, that LBO stuff's way over my head, Henry. I just can't follow it.
This is the manager. That's Henry Kraft.
Some we raise from the public sale of securities. We pay off the debt incurred in buying the company with cash from its ongoing operation, and by selling off pieces of the business.
That's French for buying people, isn't it, Henry?
So I want you to think about that. Two things. First of all, the idea is debt and firing people. I just talked to you about what we're doing in climate. We are hiring so many people today to build those factories around the country, but this is how it entered people's minds. And secondly, we had an interesting type of typecasting. I don't know if any of you read the book, but the manager, Ross Johnson, was kind of a tough guy. He was played by America's sweetheart, James Garner. This is the guy who was in The Notebook, for those of you who are rom-com fans. And who do they choose for Henry Kravis? They choose a Bond villain, Jonathan Pryce. And that has continued to today. Same time that was going on, the other leg of private equity was actually families. I'd say the best private equity firm of the 80s was probably the Pritzker family and the Bass family down in Texas. I was working for the Bass family. But the reason I go through all this, and then we'll set up, Marcy, this idea of human capital, is all that was in the 80s. But if you look in your portfolio today, and if you look at the industry, there's a series of kind of legacies and gene pools. So the private credit business, a surprising amount of it, as Gene will tell you, grew out of Drexel Burnham, people who were trained there and have over time. Lehman Brothers was not particularly well managed, but it is now the largest progeny, its progeny are the largest in the industry. And then we came from a different style. We came from a West Coast and middle of the country kind of family style. But today you still see those styles. And the reason I point that out is the decisions early in the industry shape the industry. The decisions that you're asking us to make about our people today, our practices today, they will shape not only the next few years, they will shape the next 10 to 15 years. So we have to understand the power of prehistory. And I want to thank you for your stewardship, because we have to be better, because not just for today, but for where it will echo. So if we go back out of that, like it's been an interesting run from there, much bigger than we expected, but should we talk about human capital? Or so two questions. We have capital, we have ideas, and we have people. That's the entire industry. And over time, we've realized that we need to make sure that we're nurturing and building all of them. The first question that I realized that we need to focus on over time is really getting the right people in the room. And frankly, there's a lot of science to choosing teams, but one of the things I'd point out, and I hope I don't get quoted on this, but if you look at the GE board, General Electric board in 2012, this looked like an all-star set of business people, and they didn't do that well. It turns out, I am a student of Kathy Phillips. She did a lot of work on diversity, life experience type. She actually did her diversity work by bringing different groups of fraternities and sororities together and mixing them up to see if you mixed in new people, how did you do? And she found two things. First of all, new groups of diversity always did better. But when they walked out of the room, they thought they did worse. And so creating diversity is the right thing to do, but it takes work. And so I, in my own mind, have, when I build teams, I think of a dinner party. A really great dinner party is people with different backgrounds and the same values who come together and kind of mix it up in a way that is important. So within our own business, the fastest growing part of TPG is our human resource team, because we realized we were underinvesting in our human capital. And we've had to remake everything we do. Part of our problem, if you go to the next slide, just like the industry came from a few firms on Wall Street, we were hiring from a few firms on Wall Street. So over the last 15 years, we have totally had to redo our hiring process, and we went from 10% diverse to today. Our last entry class into our investing line was 70% diverse. And that will take a while to go through the system, but it's proved you've had to be really thoughtful. It's hard to get this right. And that's not enough. We have to do, you saw our team yesterday on Next. We have to bring diversity in other ways. So we have talks at TPG where we bring diversity in. So we bring to voices that may not be in the industry, but need to be in our considerations. Go ahead, Bruno. And we focus a lot on team building. One of the things, it sounds like you have your human capital people here. It's not just who's in the room, it's how things happen when you're in the room. I recently ended up lecturing at Stanford. They called me up and said they wanted me to do a lecture on teams. I said, why do you want me to do that? But everything I've done has been in teams. And teams are about how you ask questions, how you listen, are you curious? Joe versus Lucy. Anyone read the book Boys in the Boat? So if you read that book, Joe Rance is the main character. He's someone in the 1936 University of Washington rowing team. Joe is not the best rower, but every boat he goes in for 5 years wins. No one knows how. There are people on your team that just make the team better. So you have to hire for that, not just hire for resume skills or experiences. So the point is, it's a very thoughtful, holistic approach. And finally, you have to teach people to lead. It's part of why we do Next. We're creating allyship. You know, I'd like to have our firm be even more diverse. I'm a founder. I'm never going to make myself a diverse founder, but I can be an ally to other diverse founders in a way that hopefully can change the industry. So this is a holistic approach, and I think you're asking us to be better about that, and we should. Let me tie this, Bruno, if we go back, and then we'll get off this, maybe talk climate but let's talk about responsible private equity, because it's kind of one through line, Marcy. And this is an issue that has flummoxed me. You all don't know me. I grew up on a farm in upstate New York, sort of Midwest values, try to do the right thing. Don't always get that right. But I function in an industry that has not, sometimes hasn't gotten it right, but also has really gotten it wrong in talking about how to do it right. These are the kind of headlines you face as a private equity investor. You can imagine I face it even more closely. I like the one in the upper right, Vox. What is private equity and why is it killing everything you love? Like, wow. And in fact, you know, if you look over time, the industry has had a series of evolutions to how people think about it, all the way back to that Barbarians of the Gate movie. You know, Sears and Toys R Us, perhaps private equity put more leverage on it, but actually what killed Joffrey the Giraffe was big box retailing and Amazon. It wasn't actually private equity, but the role had to be, you know, we had to as an industry discuss that together. And then on the right, the idea of private equity's locus. I think that's actually me on the right. So we announced a deal in Europe in 2006 called Groa. If you've ever traveled around the world and you turn on your shower, you'll see Groa. That was a company. It was a company that was on the edge of failure. It was owned by a German family, and we went in and restructured it. And one of the local politicians said we were locust, we were killing it. In fact, that company is now taught as the way to turn around a company in Germany. No one knows that outside of German business schools, but the locust idea sort of proliferates. And this is, if we go to the next slide, and I offer this as an observation. I'm not complaining, I'm not, you know, but it's interesting. When Boeing makes some mistakes, we call to task Boeing and those mistakes. We don't call to task whether or not we should shut down or reduce public markets because maybe Boeing had short-term quarterly pressure on it that led to something. So in the public market, company problems are company problems. Because there's so many private equity companies, often a company problem becomes an industry problem in private equity. Somebody does something in one of the 18,000 companies and the company. So it's fair always to hold our industry to higher standards, but I often am frustrated because I can answer for what we're doing. I can't answer for all that the industry is doing. And sometimes a company problem is a company problem. So we have to be better on communicating this. And we have failed miserably as an industry. So at TPG, we always looked at the private part of private equity. For 7 years through the 2000s, we did not have a website. We didn't want anyone to know who we were or what we did. It wasn't about us. And we actually put up an under construction sign. We didn't want you looking. So when you put in TPG and did a search, you found an under construction website for 8 years. And the industry The industry got to be a couple $1 trillion industry before it had an industry association. The British Venture Capital Association started in '83, Asian Venture Capital in '88. The LPs figured out they had to create an industry association in 2002. It wasn't until 2007 that 12 of us got together to do it, and no one else would join for the first 5 years. We're now up to about 300 firms, but that's only 1/10 of the industry as part of the industry association. And we're not very good as an industry association in telling our story. Let me show you a recent video on, we're trying to explain to people that actually private equity creates jobs through some legislatures. And this is the work, and it's good work.
What does private equity mean, Chairman, in New York and in your district?
It means development. It means progress. It means opportunities, and it means creating jobs.
There are some very good messages out there about what private equity has done.
This goes on, but I had someone go check. It's pretty good things, but it's hard to do. This has 900 subscribers, and a year ago it had 0 likes. We've had a good year. We're up at 994 subscribers, and we got 2 likes. The industry's voice is not very well heard and maybe not very well executed. This is our problem. We need to tell our story better. So how do we do that? At least at TPG, we have adopted, and perhaps not correctly, but we've adopted show not tell, that we don't think we're going to be able to tell our way here. We have to show you what we're doing. And first of all, that's driven in part by what you do. I'll call them LP initiatives. We're broadly aligned and we support what you guys are doing in terms of labor practices. It just makes sense. We're asked, we fill out 225 DDQs. These are people asking what we're doing on ESG, our practices, a year. Our LPs are all over us and we welcome it because it makes us better. We as GPs are doing more. We're building impact funds. We're doing climate funds. We're doing our own guidelines for responsible investing. And then we're doing things together. You and we are leaders in ownership works and ESG data conversion. So we have to actually not talk about what we're going to do. We're going to have to do it. And then on the TPG side, Bruno, if you go ahead, this is not new for us. Back in 1997, before I ever heard of ESG, we were putting in place responsible labor practices. It was just the right thing to do. That's how we're brought up. That's our values. Before we were protecting the reef through Petco decades ago. So the point is, you can do this right, but we can't just talk about doing it right. We have to work on it together, and we have to be committed to it. So I'll stop on that. But TPG Next, thank you for joining us in this. This is an effort for us to try to put the right diversity into capital allocators beyond what we can do ourselves. And if you look at our portfolio, we're growing jobs, not destroying them. So let me end on that. But it all fits together, like the history, the responsibility, and the human capital.
Thank you. Fascinating and really illuminating. And if you would just, before we go on to questions, touch a little bit on the AI and as you see it impacting, and also whether anyone's trying to differentiate themselves in that field, not just by more powerful AI, but more efficient AI.
Yeah, today you're watching 3 of the great business battles of all time going on. One are EVs. We can talk about that if you want. The second here in California is streaming, like who's going to win the streaming wars. The third thing, very early, is AI. And AI will go through an arc. And I am going to give you 3 of the most important words in investing about AI right now, and that is I don't know. Meaning I don't know exactly how this arc is going to go, and I'm waiting a little bit till I know better. What does that arc look like? If you look at the arc of the last level of technology, early on you wanted to invest in Cisco and Intel because it was about hardware. Then later it moved on to Google and Microsoft. It was about the enablers, the kind of base languages. And later on it was the apps. Uber, Salesforce, et cetera. So today, in the early days of AI, what you're seeing is people investing in NVIDIA because that's like the hardware and data centers. Next, you're going to see a massive battle to see who forms the base layer. So if you think about Google, you got to remember there was Bing and there was Netscape and Google won. So right now you're watching a race between Microsoft, with OpenAI, Google, Elon just jumped in, and that will form the base. Somebody's going to win that. There'll be a couple winners. There won't be a wide range of winners. And then there's going to be a third level of place you make money, which is essentially the apps. Once the base is there, what do you do with them? And that's where private equity, there will be a private equity AI app, and my memos will take a few less people and they'll be a few pages longer. I'm not sure they're going to be any better, but we'll have, a lot of it done with AI. And so for sure they're going to need chips. That's why a lot of people are put in. You don't know yet who's going to win the base, and the apps are still totally unclear. So watch, wait, and try to find certainty in that. One of the things I do know, one of the areas we're playing is data centers take a lot of power. So we're going to provide green power for them. I wish I had a better answer, but sometimes I don't know is the best answer.
There you go. I wish more people knew that. Questions, comments from the board? Don't be shy. Raise your hand. Let me see. Okay, Director Willett.
Thank you for the presentation. On talking about the responsible investing on your show not tell slide, and you mentioned that you support our labor principles. I'm a big fan of our labor principles. I'm wondering what percentage of your portfolio companies do you have the labor principles applying to and holding accountable to? And if someone's not accountable to labor principles or holding them, what are the ramifications?
Well, I will also say I don't know exactly that because, quite frankly, articulated labor principles are early in the industry, meaning you've started to do that. I think one other private equity firm has done it. We're looking at how we do that. But frankly, I started my career in an airline restructuring. We saved 40,000 union jobs by restructuring Continental. So everything for a long period of time, our interaction with getting our principles right has been core to what we do. So it's good practice, it's good theory, and it's good strategy. So I think we've been not always fully aligned, but we've been on that path for a long time. What we need to do now is what you've done recently at CalPERS, which we need to institutionalize it and articulate it. And I hope I'll be able to give you that number in a couple of years. But I think you can know we're aligned and you can know we're on that journey together. And I have to get a better answer because we're just now thinking about how we institutionalize it.
Okay, Dr. Pacheco.
Thank you. First of all, thank you, sir, for your comments. They were very enlightening. On following up with what Director Willett had mentioned, I've been reading several books. I think there was one book that I just read recently about private equity in the history, how in the legacy of them has destroyed jobs in terms of Toys R Us, the Toys R Us saga, and recently now the emergence of private equity into healthcare. Mm-hmm. And what we're concerned about is these they're affecting certain industries that are very close to our heart and actually to our lives in so many respects. And I know that you mentioned that you have you're starting to align with it, but from what I've read, the American Investment Council has their responsible investor documents that we actually incorporated into our labor principles. And I just wanted to know if you could elaborate a little more about that and just your thoughts in general about that, sir.
I think this is a wave of people now articulating practices. Different people in the industry have had different practices over time, and we're now setting a goal. On the LP side, I believe CalPERS in New York have been leaders on this. On the GP side, the AIC, which is our, as I talked about, our late to the game but growing industry association, is also articulating that, and I think we will together come to a good place on it. You know, we have to, as a industry, we are only going to get the returns we need if we build jobs and build companies. This is no longer an industry that you can cut jobs and ride leverage. And so I think we're more aligned than people understand. And I know within our healthcare portfolio, we are growing jobs and it's near and dear to our heart. So let's work to build alignment and make sure we learn from the good parts of the history and attack the parts that we haven't done as well.
Like you said before, you mentioned earlier, you read history. And yeah, I think it's good that we learn from history, because I definitely do not want to repeat certain parts of history in any respects. In light of that note there, we've also helped with the conversion data initiative to provide more transparency, especially in the portfolio companies. I just wanted to know your thoughts on that and what's your thoughts on that.
We are some of private equity in general, and certainly TPG in particular, are some of the biggest data hounds in the world. So I like transparency and I like data. It's harder than people understand, which is why we need to work on it together. One of the issues that we have is we don't know what you want as an LP. So the ILP a period of time ago came out with disclosure data. And so we said, great, that's fantastic. We get asked for that, and we get asked for literally hundreds of individual changes to that because people want different data. So I am fully in favor of trying to get a set of data that we can be transparent and forward-thinking, because that's what we ask of our companies. And all of us on both sides of the LPGP world should be aligned to make sure that happens. Your team has been a leader on that, but I want to say that I feel like we're in the second inning and we can be a lot better. I do want to hit an area that we are leading on and you're leading on, which is a side. And so I want to talk about Lithium Valley when you get a moment, but I'm happy to answer other questions.
That would be fine. Thank you.
Yeah, go ahead.
I want to jump back over to an area that, again, is looking forward, and that is the work Peter and his team are doing with you to think about sustainability as expressed through your portfolio is important work. And it's important work if you jump into Lithium Valley, Bruno, because this is hard. One of the things from a long time of investing, there's a really good book by Eric Weiner called The Geography of Genius. Why do things happen in some places? Like, you wouldn't have picked Northern Italy for the Renaissance, but somehow like it all came together. And the auto industry happened in Detroit. Why Detroit? There were 125 car companies in Detroit in the 1920s. Why did finance happen in New York? Like there's times that things happen. And we here in California, like why did the movie business happen in LA, right? We here in California recently have seen a geography of genius, which is this ecosystem of investors, the industrial base of the Silicon Valley, a human capital ecosystem. You have Cal, Berkeley, and Stanford have had 69 Nobels since the Second World War. France has had like 68. So somehow this area of 4 million people generated more Nobel Prizes than France. And then there was a series of entrepreneurs who built a series of companies. None of them went farther north than San Francisco. And all that happened, I used to go to tech conferences in London. I could learn more by going to a cafe in Palo Alto than I could at a tech conference in London, because you would learn it all there. There were no surprises. The problem why what you're doing is so important and why we are trying to do it globally as the largest global climate fund is I was at COP28 in Abu Dhabi, and I was wandering around. It was like a big trade show, and I had never heard of a lot of these companies. I travel a lot, and when you look at where the companies were that were at COP, they were all over the world. They didn't even know each other because they weren't going to the same cafes. They weren't, building their companies in the same place. If you look at the battery initiatives around the world, they look like this. And if you look at the hydrogen world, so there is no center to climate. But one thing that is center is capital. Capital is central to all of this. And so I really appreciate the work you've been doing to think about a different model of climate investing, true to your asset classes, but expressing a theme across all of them. Like, this is a big deal. And I think you need to voice it. Interestingly enough, the other area of climate investing where there's a lot of activity is actually the Gulf. It's interesting that Saudi Arabia has some of the biggest solar projects going on in the world right now. It ought to be California. You guys have been leaders in policy. We've been leaders in innovation, but we haven't centralized it the way we have the movie industry or the tech industry. We probably can't do that today, but we can create a centricity to where people come from capital and how to express it. And so the California model of capital, policy, companies, and innovation, I think there's a real opportunity. There may never be a lithium valley, but I do think you can help shape this industry, and hopefully we can help you as we do that together.
Okay, next time I go to team member Benvenu.
Oh yeah, I was just gonna. Sorry, I moved this forward, but I was slow on following Director Pacheco. Back to Melissa's question on the labor principles. I just want to confirm. You've signed on to our labor principles. You agreed broad alignment with our labor principles. I think your comment was just you haven't developed your own the way that some have. Is that?
Yes, we are. Okay. We are broadly aligned. We're signed on. You know, okay. And again, as I read what you're saying, I felt like you were asking us to do what we believe we should be doing. So that's the best sort of alignment. And what I was commenting on is, I think there was a question of like, have we had our own labor and have others? And I think those are still developing. So we're following your lead, but we're fully aligned.
Thank you. Just want to confirm.
Okay.
I'm sorry if that wasn't clear.
Any other questions from the board? Oh, Director Walker.
Thank you. So I have a question, it's not necessarily on topic, but based on something that you said about diversity being the key, not the key, but very important to success and how you move and the way things move. But in our country today, you have a lot of negative comments about diversity. A lot of negative comments about DEI. And I'm not seeing like industry leaders saying, whoa, whoa, it is important for us to do this or we are not going to be successful. So I just don't understand why that is. I'm not sure what my question is, but I just don't understand why that is.
I think I don't know if I count as an industry leader, but I think
you do in the room.
Yeah, I think you are hearing me say that. And if you look at what TPG and you and we are doing together, we're saying that's important, and we're doing it by showing, not just telling, and taking action, whether it's, you know, we're the last major private equity firm that's active in Africa. We're building Next together. We're showing recruiting. So we're going to show, not tell. And I share with you the frustration with the pendulum swinging back. Like the pendulum swung on DEI and ESG, and when I travel around the world, people are worried about being criticized for it today. Actually, right. we're leaning into it, and I think you just have to do what you believe in, do it well, and show, not tell. People will understand who you are by your actions. But I'm aligned with you on this, and the question is, do it.
I agree. To modify what you said, I believe more in show and tell some. Yeah. Because if you don't tell your own story, it is never going to be out there. And the story that's being told is that this doesn't work, and that, you know, it's really only used to hire people who look like me who are really not qualified.
Well, I see what, you know, what you and we are doing. For example, I'll just take Next as one piece of it, because it's obviously through the whole process, is we need to show it's successful, because that's a way of talking about it, right? And that we're out pitching that all the time. So I just want to highlight, we are aligned on this, but we all need to do a better job of showing why we're aligned, showing it works, and showing our actions. but I'm not very good at showing up at conferences for reasons I just talked about. So I'm going to keep working.
Thank you. Any other questions, board members? All right. Well, thank you so much. This has been just fascinating, and really appreciate the time and the time the staff and everyone put in coordinating and pulling this together to have you here to spend some time with us. And I appreciate it. And thanks from me and the rest of the board. And at this point, we now have several callers for public comment. It looks like we've got 4 callers on this item, so we'll open it up to public comment.
Yes, Vice President Miller, we have Mark Swabby, a state retiree.
Go ahead, sir.
Yes, hello, I'm Mark Swaby, a state retiree after 32 plus years of civil service. Thank you for allowing me to speak. First of all, Mr. Coulter says he doesn't know what we want as an LP. I'll tell him what we want. We want money. We want an equivalent annual return to 15% with $1 billion profit on exit from our contracts with PPG. My other comments on private equity investment opportunities for CalPERS as follows. I am opposed to CalPERS investing more billions of our precious pension fund money into private equity contracts for the following reasons. CalPERS, as is its own chart of private equity investments from 2023, showed we were invested in 341 companies with. Hello.
We can hear you, sir.
Oh, I'm
Continue.
sorry. Yes, let me continue.
Okay, it sounds like you've got sound on there
Okay,
that's
one
interfering.
moment. Yeah, I know. I'm cross-talking myself. Frank, turn this down. You're 10
Yes,
seconds
please
behind.
do.
I'd like to remark that for my comments earlier this year to the board, an individual investment of less than $500 million cannot return more than $1 billion to CalPERS. Closer inspection of the charts from the 2023 report of CalPERS showed that we had some forever contracts with some companies, including one dating back to 1999, a few dated between 2000 and 2010, more were dated between 2010 and 2015. The chart indicated that we were possibly investing returns from some of these completed private equity contracts into new contracts with the same companies because we had no clear profitable exits for many of these forever contracts. These forever contracts had exit fees that would severely reduce any returns to CalPERS. And for other reasons, Fifth Circuit Court of Appeals recently ruled against the Security and Exchange Commission's attempts to regulate the private equity industry, keeping investments in private equity company contracts less transparent and more risky. This undermines CalPERS' mission to keep its assets under management secure for state retiree pension payouts. Additionally, the outsized investment returns have not been forthcoming since 1999. I propose a different way of investing in some private equity companies. I discovered through some public equity research that some of the larger private equity companies, including TPG, are publicly traded on the exchanges.
Okay, if you could wrap it up.
TPG, okay. TPG common stock, which currently pays a dividend of 40 cents per share for a 3% dividend per year. A $2 billion investment in this stock would purchase more than 50 million shares of TPG, which would provide TPG with the capital to enter into profitable contracts, which would increase its share price or increase its dividend or both.
Yep, you've run out of time, sir.
Thank you.
Okay, thank you for your
Bye.
comments. Next speaker.
Our next speaker is Fernando Garcia Cruz from the Los Angeles Tenants Union.
Thank you for
Go ahead, sir.
Hello, everybody. Thanks for having me. I'm speaking to you from the Los Angeles Tennis Union, asking you to take a close look at your relationship with CPG and the ongoing harm that they do to tenants in Los Angeles, and specifically in Koreatown, down the street from the UCLA building. In 2019, funding from CPG played a part in the displacement of working-class families when they assisted K3 Holdings in purchasing 14 multifamily rental properties, total 400 units, and the aggressive and predatory practices that destabilize rent control, reduce the quality of housing, and in some cases, evicted 3/4 of the tenants in a building. And this is a small example of the national negative impact of CPG on our communities. All of this, the racist and violent social cleansing of low-income Latino immigrant and indigenous communities, all of this was made possible for K3 with the support of CPG's financial and logistical support. I hope that y'all, as y'all in the teachers union, who recognize that a student's education is contingent on a community, on the basic needs of our students being met, and that as a teacher, there's only so much one can do to support students thriving. And as teachers and as a union, this is a great opportunity to ensure that we are providing our students with the best possible circumstances for their success. The presentation just given has many key and attractive words about green investment and responsible private equity, and I encourage the United Teachers Union of Los Angeles to parse through these narratives of responsible investment and look at the impact you all as teachers and as a union have on our community. We ask that you consult with CPG to consider their role in financing enterprises that defraud and harm hardworking immigrant families into evictions, homelessness, and death. If CPG and K3 Holdings cannot help rectify at least some of the harm caused to tenants, they must be divested from. Thank you for your time.
Thank you. And our next speaker.
Our next caller is Frank Ruiz. Go ahead, Mr. Ruiz.
Go ahead, sir. Do we have our caller? Can't hear him. I think you might need to check in with him, Kathy.
We can ask him to call back.
Okay, let's move on to our next caller and we'll come back to him then.
Okay, our next caller is Les Kessler from Los Angeles Tennis Union.
Hello, my name is Celeste Kessler. I am from the Los Angeles Tenants Union and the K3 Tenants Council. I would like to emphasize everything that was shared by my colleague Fernando about the way TPG has enacted immense amounts of harm here in Los Angeles by financing K3, a real estate investment firm that displaces low-income immigrant tenants from buildings here in the community in order to replace them with people who can pay higher rents. This has been well documented by several major media outlets, and I would like to urge everyone to look more into it by going to k3tc.org. There you can also learn how tenants are fighting back against these companies. Several tenants are on rent strike and have been for several years in order to demand their original lease agreement that they were coerced and forced out of through harassment and intimidation by K3. And they are demanding those contracts back. You can learn more about their struggle, again, at k3tc.org. We urge everyone here listening to demand that CalPERS cut ties with K3 and TPG and to support tenants, low-income immigrants, and all people struggling for a just and diverse future, given that diversity has been talked about so much in this meeting. I would urge you all to again look into all of this at k3tc.org. Thank you.
Thank you. Okay, do we have our other caller back on?
No, he's not back on yet.
Okay. Okay, we'll move on. I have a question. Oh, from, okay, Mr. Rubalcava. Microphone.
Thank you again for your presentation. It was very enlightening, especially the historical evolution. You are. But I'm trying to understand. I know you went through streamline to the PowerPoint, but there's one that we didn't address, and it's called "We're the Log Jam Moment."
Yeah.
If you could explain what that means.
So let's maybe jump into the Mark Twain. So one of the things that's hard sitting on your board is to get the historical perspective of how this industry moves. And if you go in the middle, Bruno, I would ask you to remember Mark Twain, who famously in the late 1800s was in London, and it was cabled to him that it was reported in New York newspapers that he was on death's bed about to die, and he responded by cabling back, "The report of my death has been grossly exaggerated." So in the private equity industry, one of the things I can bring is in 1989, people declared the end of the private equity industry when it was a $30 billion industry. Today it's a $6 trillion industry. And it was about that the industry was over leveraged. It wasn't going to be around for the long term. They again declared that the death in 2001. I remember in 2008, my then 16-year-old daughter walked down one day and said, "Daddy, are you okay?" And she was reading the papers. Private equity is dead meat. Private equity is now worthless. Party is over. The model is dead. As late as 2015, which was like a boom period for private equity, the Wall Street Journal, which is supposed to be our in-house organ, even though it's not, declared that, stick a fork in it, private equity has peaked. And recently, there's been a lot of activity around this question of like, how do you think about private equity? And if I can leave you with one thing on private equity, it's when it feels bad, it's good. And when it feels good, it can be bad. So the industry grew for a period of time from 2013 through the public. And recently, it has seen a drop in deals. That creates, and excuse me for the long preamble, but that creates a logjam, because what happens is you've made commitments and deal volume goes down. Think of it like an inventory correction, like you have too much inventory for a period of time. And it looks like this. And what I'm showing in this next slide is a graph of how much dry powder there is in the industry versus how much activity is. Those peaks are log jams. At a period of time, it looks like you've got, this kind of moment that's frozen. And it doesn't feel very good at that moment. What history tells you actually, though, if I just go to the next slide, is what's interesting is if there's a problem and a moment of problem in the industry, it's usually right before the log jam. The vintages in the log jam tend to overperform. So this point of like when it's blowing and going is when you need to show some restraint. We were a net seller in 2021. And actually when it's a little tougher is when you need to kind of make sure you stay the course. CalPERS is in an extraordinarily positive position right now because you have capital to deploy into this industry class at a moment that the industry class is in a logjam. And every situation is different, but the log jams are often when you can get across the river, and this is an interesting moment. So thank you for calling that out, but that's what I was trying to.
Thank you. Director Willett, did you have a question, or did we get you? Okay, so we'll go back. I believe our last caller is back on. So if you could bring our caller up.
Yes, Mr. Miller, Frank Reese is on the line. Go ahead, Frank.
Okay. Can you hear me okay? Hello? Hello?
Yes, we can hear you, sir. Go ahead, Mr.
Hello?
Ruiz.
Can you hear me? Oh, okay.
Go ahead. We can hear you.
Thank you for the opportunity to address the CalPERS board members. I am a CalPERS retiree. My theme is the same as the last time I made comments: achieve benchmarks today, meet pension needs tomorrow. On July 2nd, 2024, CalPERS announced a $10 billion investment increase on climate change projects. In June, my comments I suggested a review and evaluation of private equity investments. As we know, private equity has not delivered the promised outsized profits for decades. CalPERS can purchase stock in private equity and maintain control of its dollars. Some private equity companies pay annual dividends. This would provide CalPERS with a revenue stream. CalPERS can sell the stock if the market cools. Most importantly, CalPERS has those hundreds of millions of dollars to invest in other investment opportunities without having to pay annual fees and contract exit costs. Further, CalPERS is not bound by a contract to keep the money in private equity, even when private equity is not making a profit. In addition, this kind of investments provides transparency that is not available in private equity investments. CalPERS has no idea if its funds have been invested or if its money value is going up or down, or if no returns can be expected within the first, second, third, fourth, fifth, etc. years ahead. As a result, by investing in public equity, CalPERS can increase the investment earnings contributed by its investments from 56 cents to 57 cents or 58 cents. Each cent represents hundreds of millions or billions of dollars. This is especially true today because many baby boomers retired. Contributions from active contributors was considerably reduced. Investing in public equity can make up or even increase the investment returns for the decrease in active member contributions. At this time, CalPERS is chasing the white rabbit from Alice in Wonderland. The white rabbit in this case is the promise of outside returns from private equity. CalPERS will never catch up to the white rabbit and its investment returns that were experienced from 2010 to 2018. CalPERS can see the investment opportunities and returns in the public equity marketplace. In this manner, CalPERS will achieve its benchmarks and meet pension needs for tomorrow. Thank you for allowing me to make comments on this topic.
Thank you, sir. I believe that's all of our public commenters. Okay, anything else from the board members? Okay, once again, I'll thank you very much, and we really appreciate it and enjoyed it. Thank you.
Thank you all.
Okay, and if Dr. Logan will make her way back up, we will continue part 2 of her presentation. And this will be on enhancing our behavioral health services. So. Okay, let's go ahead and get settled back in and get started. You have the floor, Doctor.
My name is Julia Logan. Thank you, Mr. Miller and members of the board for having me back. We're going to switch gears a little.
Get a little closer to the mic would probably help. Okay, people, let's keep the chatter down or go outside. Thank you. Go ahead, Dr. Logan.
Okay, thank you. I'd like to switch gears from my earlier conversation about quality and equity and talk now about our ongoing work on behavioral health, which, as you all well know, continues to be something we wrestle with, particularly related to access and workforce, as you just heard from our panel this morning.
So a quick overview of our discussion. First, I'll review some data with you that we check in on every year with you all to see if we're seeing any trends that we need to be aware of or concerned about. Then I'll briefly talk about our member experience results for 2023 as they relate to behavioral health. And finally, we'll move on to some initiatives that we're working on and changes we've made to our contract around behavioral health quality, access, and workforce. This first data slide is our behavioral health prevalence data from 2019 to 2023, broken down by basic and Medicare members. As you can see, and we've reviewed for the past few years now, there's been a steady increase in the prevalence of behavioral health conditions for both basic or commercial and Medicare members over time. And this includes our PPO and HMO members. The increases are small, but noticeable and important, and they're primarily seen in anxiety and depression, and seen both in basic and Medicare. And it really reinforces our decisions to include depression screening and follow-up measures in our quality measures list, as I mentioned earlier, so that we can track how our plans and providers are doing with screening and intervention for depression. This is a similar slide, but now for our adolescent members, ages 12 to 24. We continue to monitor adolescent behavioral health, specifically because this age group continues to struggle profoundly, as we've discussed in the past. And you'll notice from the slide that depression and anxiety rates remain higher since the pandemic. And we're paying particular attention to these increases, and it's been picked up by media sources, noting a sharp rise in post-traumatic stress disorder in college students, with the rate doubling between 2017 and 2022, and thought to be due to broader social, societal stressors. And PTSD can certainly manifest itself as anxiety and depression. This slide captures the 2023 prevalence rate for a variety of mental health conditions for our basic and our Medicare members. It really shows you the breadth of mental health diagnoses that our members are facing. And as you can see again, anxiety and depression are by far the most common in both basic and Medicare. And understanding condition-specific prevalence rates helps us recognize the scope and impact these conditions have on our population, and helps us raise awareness and reinforce the need for strong support networks and accessible treatment. This slide captures the 2023 prevalence rate for substance use disorders for both basic and Medicare. You can see that alcohol use disorders are the most common. About 20,000 Californians die every year due to excessive alcohol use, and that shortens the lives of those who died by an average of 25 years, so it's pretty significant. I think that we may often overlook substance use disorder treatment when we think of access for behavioral health, and this slide is really intended as a reminder for all of us that substance use, whether it be due to alcohol, opioid, or another substance, continues to be a critical issue here in California and among many of our members. In 2021, the U.S. had over 106,000 deaths due to drug overdose, the highest rate on record, and a 50% increase in drug overdose deaths from prior to the pandemic, which is obviously why it's critical to continue to monitor these rates to gain insight into the scale and impact of substance use disorders on our members. Next, I wanted to talk about our health plan member survey. This has been something that's been a really helpful tool for us all to understand where we may need to improve around access and experience of care. And we break it down by our HMO plans, our PPO plans, basic and Medicare. And because it's so important, we do it annually for each plan, and I am always thankful to our members who have filled out the survey. We can see changes year to year that we can react to more quickly. We just received our 2023 preliminary results from the survey, and we're seeing something that appears to be reassuring along behavioral health access. A higher percentage of our members reported receiving the behavioral health care that they needed right away, so urgent care services, in 2023 than in 2022. And a higher percentage of members reported being helped by their counselor or treatment that they received than in 2022, both of which are very encouraging. We do continue to see a slight decline in telehealth for behavioral health, as you might expect post-pandemic. Next, a bit about our work to improve access to behavioral health, particularly in our PPO plans. As part of our recent solicitation, we focused quite a lot on access issues around primary care and behavioral health. And as a result, we're contracting with Included Health, our population health management vendor, to do several things. And Don mentioned some of that this morning. First is to provide care coordination and care management to our sickest members. The second is to provide care navigation or assistance in finding needed care for all of our members, and to provide virtual primary care and behavioral health services to fill in the gaps, as it were. And I wanted to focus in a little bit about that virtual care. While we absolutely believe in the importance of in-person behavioral health care, we also recognize these access issues that we've talked about in behavioral health. And we also understand that some members prefer the convenience of a virtual care therapist or psychiatrist, and the format itself is conducive for that for many of our members. The virtual health providers through Included Health provide behavioral health care in the context of an integrated collaborative care model, which means there's communication between a primary care clinician and the behavioral health clinicians, which is so important. And Included Health also curates its behavioral health network to ensure that the care is being provided by an appropriately credentialed, high-quality provider. And this is also important. And it offers providers from an array of cultural and ethnic backgrounds. The care navigation services provided by Included Health are also crucial. These care navigators are trained to screen for mental health and substance use disorders during the context of all inquiries. So they're utilizing each contact with a member to determine if additional resources are needed for members. So over the next slides, I'll be walking through some really important behavioral health initiatives that we're engaging in for 2024 and the next year, 2025. Two of these are Timely Access Survey and our Look at Grievances and Appeals are designed to identify and address barriers to access and to address stigma. And finally, I'll talk about our partnership with numerous state entities on access, investment, and workforce. While we hear about the difficulties our members have in finding behavioral health care providers or getting an appointments, and I know that you all hear that from your membership as well, we don't really have a great way to understand what's happening at the practice level or where we need to really focus interventions. And so for that reason, we've engaged researchers at UC Davis to conduct what we call a secret shopper timely access survey of both our HMO plans and our PPO plans and their providers to assess how easy or difficult it is for our members to get an outpatient mental health appointment with a therapist or with a psychiatrist. The researchers at UC Davis will review our health plan networks and providers and develop a methodology for targeting behavioral health provider offices at each plan. So the power of a secret shopper survey is that it can achieve a realistic and unbiased perspective of the patient experience, which we talk about is so important in trying to schedule an appointment. Secret shopper surveys are a really important way to check that our networks are adequate and ensure that we don't have ghost providers and that our plan networks are as advertised. We plan to have a report on our findings by next year, which we will definitely share with you, and we'll certainly share findings as we learn them along the way. In addition to the secret shopper survey, We'll be continuing our ongoing work to analyze our grievances and appeals to look for any concerning trends around behavioral health access. Between 2022 and 2023, grievances and appeals related to behavioral health actually decreased somewhat. While that's encouraging, of course, we're continuing to monitor these cases to ensure we don't miss any spikes or any issues that bear looking into. I did want to highlight a few important contract changes that we've made that strengthen our ability to monitor behavioral health access for our members. We've implemented increased contractual protections for mental health parity. We added contract language for both the HMOs and the PPOs to ensure that mental health parity is preserved. We're also requiring our health plans submit all of their data around prior authorizations, including any behavioral health services that require prior authorization, and we'll be examining samples of that data to look for barriers to care. This is something that we all have talked in the past, and I wanted to focus in on it again. Much of our work around behavioral health, including improving access, increasing awareness and education of benefits, is done in the hope that these efforts will help reduce persistent stigma that still exists in seeking care for behavioral health. To that end, through our contracts, we've required our HMO and our PPO health plan staff and providers to receive training focused on cultural humility and diversity, equity, and inclusion. We've also required the use of national standards for culturally and linguistically appropriate services, and we contractually require the use of interpretive services when necessary. We're requiring social drivers of health screening and matching positive screenings with community resources. And as I mentioned earlier, we've also required all of our health plans, both on the HMO and PPO side, to have a member advisory committee to incorporate member feedback around behavioral health. Finally, our health team is engaging in a member education and resources webpage on the types of available behavioral health services and how to access them. As you can see, we're doing everything we can to make members aware of the services available to them. We know it can be difficult to access that information. We want to make sure that our members are able to seek a mental health or substance use disorder appointment, and we want them to know that seeking that help is just as important and routine as seeking help for physical health services. Next, I wanted to talk a bit about our work with partners related to behavioral health investments, and our panelists this morning spoke about this as well. You're all aware that the Office of Healthcare Affordability has spending targets. In addition to that work, OCA is also statutorily required to examine and set targets on how much healthcare spending goes to behavioral health. They'll make recommendations on how to shift more resources to focus on integration of primary care and behavioral health. In addition to examining the behavioral health spend, they're required to promote improved outcomes in behavioral health care through several different mechanisms that are outlined on this slide. And I won't read them all, but you'll notice that each one is aligned with what we've been working on with our purchaser partners and through our contracts across our entire program to improve behavioral health quality and access. We'll continue to work closely with OCA, and of course, Dawn is on our board so that we remained aligned in our efforts, and we'll update you along the way on our collective progress. And last, I wanted to acknowledge that our members' behavioral health needs are intimately integrated with their physical health. Our work in behavioral health, whether it's adding supplemental virtual services, working with OCA, engaging in our secret shopper survey, are all really done in order to integrate healthcare services as much as possible so that our members can get the comprehensive whole person care that everyone needs and deserves. And that's why we're continuing our work on expanding advanced primary care and promoting coordinated care between behavioral health and primary care. Before I open it up for questions, I just wanted to touch briefly on the issue of healthcare workforce. We're so glad to have our panel today, and I really hope that was helpful to you to better understand where we fit into the healthcare workforce system, and we will update you along the way of our progress with that as well. With that, I wanted to thank each one of you for your time today, for your advocacy in improving behavioral health for our members. I wanted to also thank my dedicated colleagues at CalPERS who live and breathe this work every day and are really passionate about it. So thank you to the team. And I'm happy to answer any questions and look forward to the discussion.
Hey, thank you very much for the presentation. As everyone here knows from prior meetings, this is the whole issue of behavioral health is something that's very near and dear to my heart. And it's very encouraging to hear that, you know, we continue to push forward that the importance of behavioral health along with physical health, the total interrelationship, and, you know, trying to hold providers more accountable and move it forward. So I really appreciate it, and I really look forward to, you know, our continued progress. So any questions for any board members? Mr. Rubalcava?
Thank you, Dr. Logan, and thank you, Mr. Miller. I want to follow on Mr. Miller's comments, and actually that was I want to speak also to the earlier, the equity, the quality and equity presentation you did before lunch, and which is basically you setting up financial accountability and quality measures. And today, in the whole thing about the push, you know, the integrated care, and something I've raised in the past, which is something you've incorporated now, especially because of our new people arrangement and included health, is screenings at the PCP setting. And so we now have the matrix, now we have the measures, quality measures, and financial accountability. So the question is, how soon can we see the results of those new initiatives? So we can, is it going to be looked at quarterly, yearly? How soon can we get reports back? Because we wanted, I mean, I'm confident that these screenings for, like I think I've raised before, this whole thing about comorbidity. And, I mean, that first place they could see it is a primary care. And now we're going to even extend that to PPO, and it's a beautiful thing, but we want to make sure that that our members really see the results of that and the outcomes, I guess. So my question is, how is it being recorded? How is it being reported? And who's going to be looking at that data, and how do we summarize it for the board and see what else can be done? Thank you very much.
Yeah, and that's a really important piece of all of this is the results, obviously, and then reporting our results. And we intend to report the results publicly, so we will be posting the quality measure results in our annual report, the HB-PAR, and we also intend to report them in facts at a glance as we get them. The first year that the plans will be accountable for that is this contract year, so 2024. We will not get the results until next year because these quality measures are a look back. But that is our plan, to post them publicly to make sure that there is transparency and accountability.
Oh, that's great. Thank you, Dr.
Ms.
Thank you, Mr.
Gallegos? Push your button. There you go.
There we go. Thank you. And I think this is along the same line, but I think it bears repeating. And it might be a rhetorical question, but Congress legislated in 2008 the Mental Health Parity Act, Mental Health Addiction and Parity Act. But it doesn't seem like that legislation has had teeth because we're clearly not at parity. How are we going to hold our insurers accountable? We did hear from you about the quality measures. I'm not sure if they're behavioral health specific that we're going to be holding them accountable for, but this has been legislation since 2008, and we still do not see movement towards parity.
Yeah, thank you for that question. The Mental Health Parity and Addiction Act was, there was one, the first in 2008, and then there was an update in 2013. And we hold our plans accountable to MAPIA, which we call it. So in our contract this year, and we realize that it's hard to have that accountability if you don't necessarily see it. So we are requiring our plans to report on it, how they're accountable, and also around non-quantitative treatment limits, because there's the quantitative treatment limits that's around copay and cost and things like that, and then the non-quantitative treatment limits are around things like prior authorization. And so we're having our plans report on prior authorizations, specifically in behavioral health, so we'll be able to see that information. In addition, we rely on the Department of Managed Healthcare as the regulator to hold the plans accountable to MAPIA as well. And we have regular discussions with them about that accountability. And I know that they do what they call desk reviews of behavioral health in the HMO plans. In addition, they do deeper dives into behavioral health, and they do specific behavioral health surveys on plans. And I know they're planning to do 25 behavioral health plans over the next 5 years. And we're keeping in contact regularly with DMHC about that.
Great. And I failed to say thank you to staff for making this a priority, because I do think it's worth our time.
We're right there with you. Thank you.
Okay, next, Dr. Willis.
Good afternoon. My question is, why do you think that these mental health conditions increased during the post-pandemic era?
Yeah, I think about that a lot. And like the last speaker, I'm not sure I know the specific answer. I think it differs in different populations. I think adolescents have a particular set of challenges. I mentioned their rates of anxiety and depression are going up. I think social networks are very important. There's some studies recently about the importance of social networks in adolescents and how they sort of feed off of one another. And social media is also, I think, if an adolescent, don't quote me on this, but I read it recently about if adolescents spend more than 3 hours on social media per day, their risk of anxiety and depression increases by 50%. Wow. And so there's just so many stressors on adolescents and adults and in different ages throughout the lifespan. I think it's multifactorial for sure.
Yes, the suicide rate has gone up as well.
Yeah, and that's why prevention is so important, that having that coordination of care between a behavioral health provider and a primary care provider is so crucial, because of that early screening can prevent further things down the road.
Thank you.
Any other comments from the board? Okay, thank you. Yeah, I just also want to, also mention that with the move to more screening, being more preemptive, being more proactive, and in the long run, it would be really nice to think that we could get it kind of on a par with kind of preventive health maintenance type models that we use for integrated care management, to include the behavioral health aspects, to include the dual and multiple diagnosis, including mental and behavioral health issues as well as the physical, because right now they tend to be, there's a disconnect often. There's not that early recognition, and how much in a family care in practice, any individual has the potential to have those knock-on effects and profound impacts on those things with others, and they're rarely alone, especially when it comes to substance use. And so to me, again, taking the lead and putting our money and our legal, horsepower where our mouths are, and putting this stuff into, actionable terms with our providers is, to me, it's huge, and it's very encouraging, and I'm just really excited to see the results and in the long term, continue that movement toward a truly integrated patient care models that are whole person focused, not disjointed like they currently are. So thank you very much to you and all the staff and all the thought leaders and everyone that you've interacted with on this, as well as our providers for, coming along with the ride, maybe being dragged along, but, we're going to take them there.
Thank you.
Thank you. And at this point, we'll take a 15-minute break and then come back and continue our agenda. benchmarking score for 2023. And here to present, we have Kim Malm, Deputy Executive Officer for our customer service and support team, and Chris Dahl from CEM. Ms. Malm, I turn it over to you. You have the floor.
Thank you very much. Good afternoon. I'm here today joined by Chris Dahl from CEM Benchmarking. Chris joined as the Director of Client Coverage in 2023 and is responsible for the U.S. market. He brings over 20 years of asset management experience with a focus on client relations, product management, and development and marketing. The report that will be presented to you today is based on the 70 global pension systems that participate in the benchmarking service, yet focus on our custom peer group of 11 pension systems for the 2023 calendar year. You will see how CalPERS pension administration compares in complexity, cost, and service scores compared to our peers. So I'll go ahead and turn it over to Chris Dahl.
Thank you, Kim, for the warm introduction. Good afternoon, Mr. Miller, Ms. Frost, fellow board members, and CalPERS leadership team members. It's my distinct pleasure to be with you here this afternoon to walk through the results that Kim just mentioned. By way of quick introduction, CEM exists to help plans do better for their members. We're a fully independent third-party company that provides global benchmark reporting on cost and performance to participating pension plans for over 30 years. We also provide peer-to-peer exchange of insights, data-driven research, and communities and practices. As Kim mentioned, I will be reviewing your results on the pension administration side of the business for complexity, cost, and service versus a peer group. I'll be sure to leave time for questions at the end of the presentation, but my presentation does weave throughout, so I will likely address questions as I go along, so please hold your questions till the end. Sorry, next slide, please. I'm going to miss that at some point, so someone keep me honest. There are three key takeaways from your report that we'll dig into throughout today's presentation, and they include the following. So on complexity, CalPERS remains the most complex plan within our universe with a complexity score of 59 versus a peer median of 40. We see that plans with high complexity like yours have historically had higher impact on costs, service, and productivity. Costs, your costs were $194 per active member and annuitant. This was down 13% year over year. Your costs were about $64 above the peers, driven by your high cost labor environment and, as I mentioned earlier, your complexity. And then finally, on the service section, your service score was 84. This was above the peer median of 79, and your trend over the last years has been stable. So those are the highlights. Over the next 20 or so slides, I will go into each of those individual topics in greater detail. So next slide, please. The insights included in this report are based on the 70 pension plans listed on the slide here. These are spread across the United States, Canada, and Europe, 32 of which are based in the US. During my presentation, when I reference the universe or all average, I'm referencing these 70 plans. But in addition to these plans, we also build a broader universe. From this broader universe, we build a custom peer group. Next slide, please. So for the purposes of peer-to-peer comparison for your pension administration costs specifically, we look to build benchmarks where peer groups are based on a similar size. Given that you are the largest plan by active member and annuitant in our universe, that's obviously difficult to do. So we've tried to build a peer group that is representative of the largest plans within our universe. We believe that this peer group is representative of that. For those of you that have reviewed the report in the past, you'll see that there are more names on the list than in years past. We have added 3 new names. So Washington, Ohio, and Pennsylvania are all new to the report and help build out a more robust picture and analysis for the purposes of peer comparisons. Next slide, please. So I'll start with complexity. Your complexity remains the highest amongst the universe. In addition to being the highest overall, you have higher complexity scores than your peers in 11 of the 13 categories listed on the right side of the slide, with the exception of multiple plan and overlays and purchase rules, you are higher in every other category. This complexity is driven by a number of key areas. So customizable options available to your members. Your complexity score was 66 versus the peers at 15. Pension payment options, your complexity score was 59 versus 39, and multiple benefit formulas at 64 versus 52. They are weighted differently, so I have given you the ones that have had the biggest impact on your overall complexity score. So why is this important, looking at complexity, especially given your size? It has a number of impacts that can have a negative overall result. So that it has a negative impact on service because the members on the team have to know so much about all the various options that are available to their plans. So that is more time consuming in managing those calls that are coming into the call center or programming services through the website. There is an increased cost, which is pretty straightforward. More complexity, there's more things to program and more people to have on the lines. And then there's a reduced productivity because things take a little longer to work through. Next slide, please. Your cost per member was $194 per active member and annuitant. This was $64 above the peer average of $130. New to this report this year is a separation of major project spend from business as usual. In the past, we had lumped it all together. Given that we're really trying to compare the report on an apples to apples basis, business as usual cost is really what is going on the day-to-day to run the business, and major project spend would be meteor items that take place once a one-time expense or a system enhancement or a modernization. So your business as usual costs were $192 and $74 above your peer average of $118. Your major project spend was $1 and $10 below the peers. Over the next few slides, I'll break down both the business as usual costs and the major project spend into greater detail. Sorry, next slide, please. So the chart on the left, your business as usual cost per member ranks you third amongst your peers. On the right side is the costs broken down by different activities. So within your business as usual spend, you are higher than your peers, peer averages across most of the categories, with IT spend, building cost, governance and financial controls, and member transactions driving the bulk of those costs overall. Drawing this back to my comments on complexity, these are some of those areas that we would expect to see higher given the very complex nature of your plan. Sorry, next slide, please. On the major project side, 2023 major project spend was well below the peers and included IT system improvements, information security risk metrics, and IT backup disaster recovery. Other programs also included replacing the call center software and upgrading knowledge management tools. I do want to add one caveat here. We know that CalPERS leadership has initiated a business process improvement project, which was not reflected in these results this year, but we anticipate they will be reflected in next year's results. So while this is a low figure in 2023, given the large scope of the project for business process improvement, it is expected that this figure will increase next year. Your 8-year multi-average was $12, which was in line with your peers at $12. Okay, next slide, please. The following is the attribution of your costs versus peers across 4 key areas. So the first is your FTE. So you have more front office employees per 10,000 members. You have 5 versus peers at 3.5. This is having an impact of $23 and contributing to why you're a little bit more expensive than your peers. The second one is third-party costs. You're $7 versus $6, so very similar to the peers and what you're paying in third-party costs. So that would be consultants, travel, education. That's typically what falls into that category. On the third item, your higher cost per FTE. So you're $5 higher per member. This is driven by higher salary and benefits and HR, building costs, which were offset by lower IT desktop network telecom. It should be noted that according to the Bureau of Labor Statistics, the labor cost in your area is 28% higher than your peers. And so that's contributing to that salary and benefits line item there at the top, and what's resulting in that line being higher than your peers overall. And then sort of the last section, section 4 here, you have higher support costs per members. This is driven by higher governance and financial controls at $21 versus $11, higher IT strategy, database and applications at 52 versus 31, and higher actuarial, legal, and audit fees at 32 versus 16. So overall, your costs are $64 above peers. Next slide, please. As I just mentioned, this is just a brief slide to illustrate the cost environment. These are the jurisdictions that your peers operate in. You can see that you are the second highest jurisdiction on the cost of labor results based on the Department of Labor Statistics, and 28% above your peers, so that's contributing to some of those costs. Next slide, please. And so the last slide I have on cost is your cost trend. So your cost trend has decreased by 3.9% per annum over the last 8 years. During the same period, peers saw their costs increase by 2.4%. It should be noted there was a major project spend in 2016 that will roll off next year. This is a big contributor to some of the declining costs that you've seen over the last 8 years. So just wanted to highlight that. Year over year, your costs were down 13% compared to peers, which were up 3% over that period. So next slide. So I'm going to pivot from cost now into the service side. So we have a new service model that we implemented last year. I'm just going to spend a couple of minutes highlighting some of the changes and what drove them, and then I'll dig into your results specifically. So it had been a number of years since we made any changes to our service score, 8 years to be specific. So that was a big driver of this. What also happened was we had a pandemic, which accelerated digital adoption quite a bit. And so between the length of time from our last update and the pandemic accelerating digital adoptions, and a lot of members now requiring digital first to access their member benefits and whatnot, those were the key drivers in why we made the changes. The changes that we did make break down like this. So we introduced member journeys. We'll have 4 member journeys that we'll walk through with you in a moment. There'll be an active member journey, inactive, retiree, and annuitant. We've increased the focus on digital services and targeted campaigns, reduced the number of questions, including removing the less relevant service metrics altogether, and we changed the service score metrics in a few areas. And the example that I like to use here is we've increased the call wait time for a perfect score from 60 seconds to 120 seconds. And then we've historically restated all the scores so that we're comparing apples to apples going forward. So what do your scores look like as a result of these new changes? Your service score, as I mentioned at the outset of the presentation, was 84 within our new model. This is 5 points higher than the peer median. And as you can see, you're the 4th highest amongst your peer group of some of the largest pension plans around the world. In addition to this, we've broken down, sorry, next slide. I knew I'd forget it. Sorry about that. So in addition to the information on the left-hand slide, the bottom right-hand slide breaks down your service score by each of those member journeys. So you are higher than your peers across each of those 4 member journeys that we're tracking. So your active member score was 78 versus 76, inactive was 79 versus 69, retiring was 87 versus 78, and annuitant was 88 versus 87. Over the next couple of slides, I will break down some of the key takeaways from each of those 4 member journeys. Next slide, please. So I'm going to start, we have 4 of these quadrants for each of the member journeys. I'm going to start on the left side and talk about the active member journey, and I'll go through each one individually. So targeted campaigns is a new area, and you scored well versus your peers. You were impacted by the targeted campaigns that you did not engage with members. So eligibility to purchase prior service credits, eligibility to purchase credit for in-service leave, and missing emails. So very simple things. I think Kim's already working on a strategy to implement those types of targeted email campaigns to members. So that will change in time. The service score there will change in time. The next section is purchases and transfers in. You don't provide real-time estimates over the phone. Written estimates can take up to 11 days, and members can't request transfers in online, and applications are processed over 1 month. So those are the couple of things that are impacting your purchases and transfers in score. Statements do not reflect pensionable earnings or the history of salary and service credit earned, and don't show future pension estimates. So that's what's impacting your member statement score there. I should note, though, that all that information is available on the website. So even though it's not on the statement that the member receives on an annual basis, it is accessible through the secure website portal. And you do get benefit for that in your secure website accessibility score, which you can see is 98 versus 93. So fantastic score there. And then finally, your call center accessibilities. So call center accessibility, all three of the call center scores, we can't segment the results by member journey. So it'll be the same score across all 4 sections. So I'm not going to repeat it each time, but the call center accessibility, the wait times, and then desirable call outcomes are impacting your score here. And that's why that's low there. So switching to the right-hand side of the slide, we'll talk about inactive members. Targeted campaigns, a couple of missing campaigns around missing beneficiaries, emails, and missing address. The rest of the service score areas are good relative to peers. Flipping forward to the next slide. So I will speak to the retiring member experience. So pension estimate self-service. So this is through the secure website. You only provide gross estimates on a monthly basis. Full points if you include both gross and net and monthly and annual, which I don't believe you do. Plus, you provide ability to view multiple estimates on one page. And then on the pension estimates assisted service, so this would be through the call center, you don't provide estimates in real time over the phone, which is impacting that score. I don't have more comments on the rest of this slide, but if we flip to the next slide, I will highlight a couple of areas where CalPERS does really well versus the peers. So I've pretty much spoken to the stuff on the right-hand side of the slide already in the last 2 slides, so I'm just going to focus on the left-hand side. So call center capabilities, secure messaging portal to allow docs to be uploaded, and history of recent correspondence. You do this better than most of your peers, and so you're getting good credit for that. Pension inceptions, 95% of all pensions are set up without cash flow interruptions within that first month of retiring. So that's a really good score there. Website accessibilities, as I mentioned earlier, members can access the history of salary and service credit information online, and it's up to date within 1 month. So you're getting full marks there. Survey program, you have a comprehensive survey program where you're engaging the member experience through different areas, whether or not it's targeted surveys for inactive members, secure website visits, or retiring experience. And then the last section, counseling. You provide more one-on-one counseling than peers, which given your size is impressive, and it's not by an insignificant amount. So 7.4% of your active members met with a counselor last year versus 2.1% for peers. So very good job. Next slide, please. So I'm going to make some comments on the call center because we did talk briefly about the call center statistics in the call center accessibilities. So your call volumes continue to remain high post-COVID. I'm going to start on the top left hand, and I'll go down and then over to the right side. So you can see that the trend remains high post-COVID. I don't see any reason why that's going to come down. You seem to get more disproportionate, larger number of calls than many of your peers in the universe. So that has remained high. Your time on the calls, though, has come down. It has trended down since 2020, the COVID highs in 2020, and you're now in line with peers and the universe. On the top, right-hand side of this slide, call wait times. Your call wait times have also trended lower and are close to the universe average and below peers. And then the bottom right chart on the slide, your undesirable call outcomes did tick up in 2022. You're below peers, but slightly above the universe. Undesirable call outcomes are going up because calls are taking longer than they did pre-COVID. It is just a broader trend. Call wait times are up, and so people are hanging up before they get through, and that's what's resulting that. Next slide, please. So this is a new metric that we're calculating. So this is digital reach. It's a measure of your self-service volume via your secure website versus assisted volume on the call center, emails, or through traditional mail. Your digital reach in 2023 was 65%, which was in line with the universe, but slightly lower than peers. Digital reach has grown by 5% per annum for your peers, while yours has remained fairly stable, increasing from 62 to 65%. So they've caught up to where you're at. And so those are my comments around digital reach. Next slide, please. And so your service score trend, the trends in your service score remain stable and consistently above peers and the universe. Some of the items that are impacting your results, call wait times increased through COVID and are now trending lower. Undesirable call outcomes were impacted by COVID and continue to fluctuate at these higher elevated levels. And one-on-one counseling and member presentations have returned to normal, which has offset challenges in the call center. So I've got 2 slides left and then we'll pause for questions. So this is our cost-effective management chart. This illustrates the plan's relative service score against relative cost, relative being against your peer groups. Thank you, sorry. Ideally, you want to plot in the top left-hand quadrant. This indicates high relative score, a relative service score versus your peers, and low relative costs. The universe the universe members on this chart are highlighted in the light blue circle, while your peers are in the darker blue circle. And your 2023 results are denoted by the dark blue square in the top right-hand quadrant. This indicates your high relative score, service score, and high relative cost. The good news is you've moved to the left from your 2016 results, where 8 years ago you had higher costs relative to peers. So your cost improvement over the last 8 years is pushing your results closer to the top left-hand quadrant where everyone strives to be. And then just to wrap up my presentation, next slide, there we go. So to recap your results, your complexity, you remain the most complex plan in your universe and has historically had an impact on cost and service and productivity. Your costs were $194 per active member and annuitant, down 13% year over year. These costs were $64 above peers and driven by your high cost labor environment and your complexity. Service score, your service score was 84 and above peer median of 79. The trend has been stable over the last 8 years. So that concludes my prepared remarks. I'm happy to take any questions if there are any.
Great, thank you very much for the presentation. And I must say, the fact that the performance remains strong and we managed to reduce costs along the way despite COVID, despite cost increases that you would expect across the board in almost it. I'm very, very pleased and impressed with the performance that this indicates. So, any questions, Director Pacheco?
Thank you, Vice President Miller, and thank you very much for your presentation. So my first question is about back to the call center and the call. You mentioned that the calls are coming. They're a lot longer and they also hang up. Is there anything we could do to kind of make sure that they don't do that and we can try to mitigate that process? I'm just trying to understand the complexity of those calls.
You want to handle that?
Well, you go ahead and give an answer first, and I'll see what, I'll add to your answer. Go ahead.
It's a volume game, right?
Yeah,
You
it's a
guys get,
volume game.
you guys are getting a lot more calls than your peers, and it is how many bodies you can have on the line to service them, especially if call times are going up. So the complexity of the complexity of the call that's coming into the call center is more so than it was before, because they're doing a lot of self-service transactions online. They're getting the information that they need. They're not calling in with those simple requests. What is my expected pension payment going to be when I retire next month, right? They can get that easily online. When they do call in, the calls are more in depth. They require more research for the call center representative to come to a conclusion and have that first call resolution, which you guys do very well, but have that first call resolution so when the member leaves, they're not having to call back a week later saying, I didn't get the result I wanted, right? So where I'm going with this is because the nature of the calls is more complex, it's driving up call times, which is having an adverse impact on undesirable call outcomes. And given that your volumes keep rising, there's sort of a compounding effect there. I don't know if you want anything more.
I just wanted to add that, our call average per day for the 23-24 fiscal year is 7,000 calls a day. And we are staffed for 3,000 calls a day. And so the volumes are going up. And our members don't, necessarily just call for specific questions on their retirement. They also call when they see things in the news. And so our call volumes go up when we're in the news as well.
Okay, so you're saying that our capacity is 3,000?
Well, that's what we're staffed for, but that's an average also. So right now during the summer, it's lower.
Okay.
And so, we're meeting our service level agreements fantastic right now. Open enrollment, there's different, cycles that come in that then increase the call volume. And so that's when it goes up a little.
I'm just trying to understand this. If there is more volume peaks, do we try to increase staff time or try to provide more time?
Absolutely. So when we know that open enrollment's coming open, we pull our quality assurance agents and all of our managers and we put them all on the phones. We work overtime. The call center works overtime in order to handle those calls. And I'll just say that our hold times, although 120 seconds is a perfect score, we're not going to ever get to that, right? But we did have last year, our hold time was like almost 9 minutes.
Mm-hmm.
And now this last year, our hold time was 6 minutes. And so the team's doing a really great job at going down, and they're getting more tools and resources online in order to help answer those questions better and quicker.
And that's actually the next question I wanted to ask. What sort of tools are you utilizing, or do you envision utilizing later to help, with this huge volume of calls?
So one of the things right now that we're implementing is a new product, My Expert, that will help answer the calls and be more predictive in what the next question is going to be, and it will help our call center agents answer those better. In addition to that, we are talking about AI opportunities where, there's an opportunity that we're looking into this year where it would do a transcript of the call, and then at the end of the transcript of the call, it would write the participant notes, which would then go into the system. And so then the call center agent wouldn't have to type in that participant note, which typically takes about 1.5 minutes. And so that should reduce the amount of time that's required on the phone also.
Can I just add to that?
Yeah, sure.
This is something that we've seen other plans around the world implement to a great deal of success. It alleviates the amount of time that the call center representative is off the phone writing notes so that they can be back in the queue to take another call. So this is both the predictive nature of where the caller's sentiment is on the call in helping the call center representative manage that call, and then as well freeing up their time post-call are both improving the member experience overall. That's what we're seeing from plans around the world.
And this technology is pretty accurate in terms of summarizing the data and the information and so forth.
There's been some parameters. Covered California is implementing this right now. And so we get a lot of, PHI data in these calls. And so making sure that this system does not put that in the participant notes. And so we're going to, we're meeting with Cover. We want to meet with them and talk about.
So there's still a lot of testing. We're still testing some of this stuff.
Well, others are. We're just starting to look at it this fiscal year.
Oh, fantastic. Then. Well, this sounds like very exciting information, and hopefully it will alleviate this incredible volume. Thank you. Thank you, sir.
Okay, next, Director Ortega.
Thank you. I had a question about the extent to which the staff and the demands on the staff reflect also the health program. So you're talking about open enrollment driving a lot of calls, and it seems like unfair to compare CalPERS to a pension fund with no responsibility for health plan administration. If so, like, is there any adjustment or accounting for that? Because yeah, I'm only familiar with one of the other pension plans in the peers, but they don't have a health plan.
Yeah. Yeah. So the results that we look at are strictly the pension administration world. We actually account for that in the survey submission that we get from the plans. Some plans that do offer both a traditional pension admin and a healthcare accounts. There's a component of questions where we'll back out that information on the healthcare side so that we're solely focused on the pension admin side.
Okay, so when we're looking at the call volume or the wait times, things like that, that would just be calls related to pension questions or pension benefits?
We take all, the number of calls that I'm referring to is all of our calls in the call center. And that's what Chris is taking into consideration also. We aren't reporting to him what calls we get that are just pension related versus just health related. I don't believe we even track that.
Right, that's what I'm getting at, is it doesn't feel like there's a control for that it's all calls. I mean, I think on the input side too, it's all staff, right? It's the staff for the.
So Kim, we do estimate, so
Okay.
it's not a perfect science, but we do estimate the percentage of calls that are related to health versus pensions, and then those are subtracted out from the score.
Okay, so then is there also like a staffing component that's subtracted? I'm trying to understand the extent to which it's all integrated and is part of the analysis versus
Yeah, I think
accounting for it.
Chris, talk a bit more about the methodology that
Yeah.
Uh,
runs behind this.
And it's dependent upon how each plan submits the results. Our guidance to the plans is this is just around the pension admin result, your pension admin world. So if you do operate a plan that has both the traditional pension admin side and the healthcare side, our guidance is do your best to estimate to back out what is cross collaborating between the pension admin support services and the healthcare support services. And so by the sounds of it, there are estimates that are taken when the survey is completed, which Kim isn't involved in, but when the survey is completed, those estimates are backed out and we're looking at just the net results.
Lorena, I'll look at that and see what that split is.
Yeah,
I get
don't-
your question.
Yeah, I
Yep.
don't think I
Yeah.
have,
Yeah,
doesn't
I
have to be
understand it.
answered here, but just a little better understanding. You got it. Helpful. Thanks.
Okay, and, Director Pelkey.
Thank you. First off, let me just congratulate the teams for their hard work. It's the numbers are really great. I did have one question. Thank you. I did have one question on, I don't know, what slide is this? It says the nature of member calls has changed in the last 8 years. And in the bottom right corner, there's an undesired call outcome as a percent of incoming calls. What's obviously I'm looking at the peer and the all average, where they're sort of steady, and then all of a sudden ours sort of does this snake looking pattern.
So the up periods in 2020 and 2021, I don't know if you can back the slide up a few. It's
17.
One more, that's the slide.
Yeah.
So you're talking about the chart in the bottom right corner?
Yes.
So the uptick in 2020 and 2021 is obviously COVID. 2022, we were starting to see a return to normal. In 2023, I suspect that might have had to do with the security breach. There was increased volumes around,
Just a little bit.
that might have played into some of the numbers.
What was the drop in 17 and 18?
Oh, I don't know if I have
Just-
insights
just
back
those were
that
the
far,
numbers
sorry.
Okay, that's all I
Yeah.
got. Yeah, I was just interested to understand why it was sort of that drastic. Okay, thanks.
Okay, I'm not seeing, Director Willett.
Thank you for the presentation and the data. It's really interesting. And I just wanted to make a comment. Anecdotally, I hear from plan participants and pensioners from CalPERS, and they love all the service we provide. And I hear really great things from our call centers. So I also just want to contextualize all of this data is real people and real members on the other sides of these things. And from what I hear, they really appreciate the work that we're doing. And I just want to, make sure that our staff knew that. Thank you.
Oh, Director Ortega.
Thank you, President Miller, Vice President Miller. I just, Ms. Willett's comments reminded me that I wanted to share additional kudos to to individual members of the team. I've had a couple instances this year of working with David Rubio to find experts on particularly challenging issues for folks who work in the administration, and they've been able to find people who've been extremely helpful, and I've just got the most positive feedback about how helpful they were to people who had very particular circumstances and needed some guidance. And so I just wanted to share that as well. Thank you.
Thank you. I'll share with the team.
Okay, thank you. And yeah, I really appreciate all the fine work that is behind this, and I appreciate the report and the complexity values also, to me, help me put it all into context, because as you say, and as Director Ortega points out, we would like to have apples to apples, but often there's significant differences, and even just having that complexity measure helps kind of put it into perspective. And again, just that we're providing the levels of service that we are, and still improving on our cost performance, over many years now is quite encouraging. So thanks very much for bringing all that to our attention.
My pleasure. Thank you for having me.
Thank you.
Thank you, Chris.
Okay. Unless I hear objections, this concludes our meeting for the day. We've had a full day of outstanding presentations, so please join me in thanking all of our presenters with a little round of applause. On behalf of the board and our executive team, thank you. Thank you also to those of you in attendance and watching online for your continued interest and active involvement. We'll begin tomorrow's session at 9 a.m. back in this room. So enjoy your evening, everyone.